I really would appreciate it if people would take their seats, please.
Don, do you still want committee members to facilitate these sessions? Yes, you do. Okay, I'm just going to let them know just so they're...
Yeah. Dave, you're going to facilitate this next session. All right. Well, thank you all for being here, guests and committee members both. I'm Don Berwick. I'm the chair of this committee and pediatrician, former head of the Institute for Healthcare Improvement, former CMS administrator, and very happy to be here. I need to make a formal statement. This is a public session, so I'm going to be reading a statement first, and then we'll be introducing the first panel. I'll say right at the start, we have a time management challenge here. Because there's so much rich stuff and so many generous people willing to speak with us at our request, we're going to really have to manage time very, very tightly, and I'm going to be a little bit obsessive about that. So let me welcome everybody first. I want to thank especially the study sponsors, the sponsors of the Department of Defense, the National Highway Traffic Safety Administration, the Department of Homeland Security, the American College of Surgeons, American College of Emergency Physicians, National Association of EMS Physicians, National Association of EMTs, and Trauma Centers Association of America. All these are supporters of the study. As part of the IOM's process, I needed to let everybody know that this session we're having now is an open, on-the-record information gathering session. The committee, as part of its work, is in the process of gathering information and materials that the committee is going to examine and discuss in the course of making its findings, conclusions, or recommendations. I want everybody to be aware, please, that the committee has made no conclusions yet. It would be a mistake for anyone in this open session to leave the room thinking otherwise, even though comments will be made by individuals, including members of the committee. These should not be interpreted as positions of the committee or of the NRC. We're going to have 5 committee meetings. This is the second. Today's meeting and the next meeting, which will be in September, will include public sessions like this, where we have the opportunity to hear from experts like we're about to hear from the field, and also to receive public comment. The committee will deliberate on all of this before it reaches its recommendations and writes a draft report. When the draft report is written, it goes through a very rigorous review process here at the National Academy of Medicine, and it's reviewed by experts who are anonymous to the committee. Then the committee responds to the review with revisions that adequately satisfy the Academy's report review committee and the chair of the NRC before it's considered an NRC report. During the workshop we're about to go into, we have the opportunity to hear from speakers from the military and civilian sectors about topics surrounding our charge, the trauma system leadership, trauma data and information systems, development, distribution, and management of clinical guidelines for trauma care, and medical education and training for readiness. Those are the topics at this meeting. In the interest of time, the speakers will be introduced by name and title and affiliation, but no more biographical information. That you have speaker bios in your materials, and I don't mean any rudeness to the speakers not to go over these. We're going to hold the questions until all the speakers in each panel have concluded their prepared remarks. I'll tell you, the most valuable time here will be, in addition to your remarks, the questions from the committee. So I'm asking you as panelists, all of you in the room, to please stick to your allotted time so that the committee has time to ask questions. It'll really enrich what we learn. Each session will have facilitators from the committee. We're going to try to provide a 2-minute warning to you, and we'll notify the speakers when the time is up. During the discussion time, the committee questions and comments take priority, and then if there's time remaining, and I'll try to make sure there's time remaining, there'll be questions from the audience if they wish to offer any. The committee does welcome input from the public, and there is a public comment period. It will follow the workshop today at 6 o'clock for that purpose. I remind everybody this meeting is being recorded. The videos and available slides from the speaker presentations will be posted on the project website soon after the meeting, and I think we're going to put the URL up there for those of you that want access to it. So let's get going to our first session. This session is going to be focused on leadership and accountability. I'm very pleased to welcome the panelists who are going to be introduced by one of our committee members, and the moderator of this session will be Dave Marcosi. Dave, the floor is yours.
Thanks, Don, and welcome everyone to our discussion today on leadership and accountability. For common understanding, this session we'll be dealing with, we'll explore military and civilian sector leadership perspectives on 4 topics. Number 1, a vision for optimal delivery of trauma care and trauma system development. Number 2, the process of priority setting to achieve optimal trauma care delivery from point of injury to stabilization. Number 3, the challenges to attaining optimal trauma care delivery. And number 4, the role of leadership in supporting a learning health system for trauma care delivery. Our speakers will be twofold, one a military sector panel and to follow on a civilian sector panel. So we'll begin with introducing the military sector panel. I'm honored to introduce Lieutenant General Doug Robb, the Director of the Defense Health Agency for the U.S. Department of Defense, and Rear Admiral Retired David Smith, Deputy Assistant Secretary for Defense for Health Readiness, Policy, and Oversight at the U.S. Department of Defense. Gentlemen, you'll have 10 minutes each. When my card goes up, that is time to expire. We will pull the hook. Don has allowed me to actually come up there and strong arm anyone, although Lieutenant General Robb, I may have a problem with you, sir. So 10 minutes for each. We look forward to your remarks.
Fights on, two's in, supporting. Got it. So, all right. Again, I appreciate the opportunity to be here. And again, I often wonder I call myself a simple flight doc doing in a room as prestigious as this. But I'm, again, very honored and humbled to help represent our military healthcare system trauma delivery in a combat environment. And what I'd like to do today is kind of set the stage. And folks that have listened to me talk before, I like to go big to small. And so I'm going to kind of give the broad sweep to kind of set the stage for the rest of today. I start almost every brief I talk with this slide. And it's important to me because this slide here, this young soldier in a remote airfield in southwest Afghanistan represents why we are all here. That soldier, sailor, airman, marine, coast guardsman, civilian, or a coalition force, okay, is the person that we are here to ensure that they are medically ready to do what they need to do, and again, that our forces are ready to take care of them. Now, there's a large what I would call a piece of equipment on this individual's back. Okay, and of course, I'm in the Air Force, and I asked, what the heck was that? And so it's a rucksack, okay? And it's important, I think it's a visual. It's a visual. Our job in the military healthcare system is to lighten the load of that soldier, sailor, airman, marine, coast guardsman against civilian or coalition force, whether it's spiritually, mentally, physically, or just good old-fashioned weight and cube. So I remind my folks, whether I'm talking to, again, to our data analyst or whether I'm talking to our clinical healthcare providers, this is why we're here each and every day. Next slide, please. This is going to be good. So, there we go. Here's the why not. This is also why you and all are here in this room today. The business we're in is nasty. Okay, make no mistake, the business we're in is nasty. And again, the men and women, and many of these folks in this audience, many of the folks at this table, again, are responsible, again, for the incredible outcomes we've had in this conflict. And we're going to talk about how we built that system. 10 years ago, 13 years ago, that individual on the left-hand side of the slide would have been automatically boarded out. Automatically boarded out. I mean, that's how I was brought up. That's how John Holcomb was brought up. That's how Ray Fang was brought up. But something happened. Something happened, and many of the men and women in this room helped change that paradigm. Helped change that paradigm. Now we've got 40 plus of these individuals below the knee amputees that have returned to combat. All right, and we also have several aviators that have returned to the cockpit. Okay, and again, it's a tribute to many of the men and women in this room. Next slide, please. Now, how did we get there? Okay, we didn't start the war. We didn't start the war again with what the outcomes that we have today. But again, it was a foresight. It was a collective, what I would call brain trust. Many of it, and I use this, and a lot of it was, and I'm going to give credit where credit's due. Okay, it's what I call John the Baptist Holcomb, who's sitting right here. Okay, and John went out there and what I call one disciple at a time, got the folks together down there in San Antonio, and then brought in the U.S. Central Command to say, hey, I've got an idea here called the Joint Trauma System, but more importantly, the Joint Trauma Registry. And so we worked it from those early days back in 2004 on. And this slide here is actually what I would call more along the continuum of what was possible. Because here we talk about, and this is one of our slides that we use, even though that the lethality rate hasn't changed as much here in the last couple of years, but the case fatality rate, okay, has continued to decrease. And so I'm going to show you another slide, but this is where we are. We are tweaking right now, okay? Again, the enemy gets a vote. Enemy gets a vote, okay, and the injuries have become more severe, yet our outcomes have remained stable or actually are getting better. Again, that's a tribute to a continuously learning system. Next slide, please. Now, when we started this war, this was the paradigm we started with. This is for planning purposes. And if you look at the evacuation policy from the battlefield to the first level of field hospital care, it was 1 day. Okay, and then it was 7 days from a field hospital to a theater hospital. 7 days for planning purposes. And then to get them out of the theater, so that would be like getting from an Iraq back to Germany, United States, or back in the previous war would be from out of Vietnam back to Hawaii, United States. It was a two-week planning process. So your continuously learning military healthcare system transformed that at the really the transition from Desert Storm into Operation Iraqi Freedom. And this is where we are. Next slide. 1 day became 1 hour. 1 day became 1 hour. Next slide. 7 days became less than 24 hours. Next slide. And 2 weeks became on routine. Routine from the point of injury, okay, 2 helicopter rides, a C-130 ride, 2 C-17 rides, and 3 surgeries later, 2 or 3, all in this 2 or 3 day period, the first time you wake up, okay, lines and tubes in every orifice and probably on a ventilator, you're in Walter Reed, okay, and your brothers, sisters, moms and dads, sons and daughters are holding your hand. Okay, that's the transformation that happened in this last decade. Next slide, please. Now, if you look at the national security, and that's what we are, you have empowered the military to do what we do. But then when you think about homeland security, you know, that's where we learn. We learn from the public that, again, helps build the foundation that we take during wartime and the stressors and transform our military healthcare system. So if you look at this, the bottom of the slide, we talked about a continuously learning system. So the Joint Trauma System, again, we're going to talk about that later. But again, that foundation, the system and the registry, real-time performance improvement. Okay, so you're going to hear from, again, our current JTS director, Captain Stockinger, and Marianne Spott. But I welcome you. There's several rooms, Eastridge's in this room, Holcomb's in this room, former directors, emeritus, as we call them, picked their brains on how we got there. Another part of our, again, our continuous learning system is you know, the requirements-driven medical research and development. In other words, we match our research goes back to what we need in the military. That's somewhat fundamentally different than the civilian sector. Okay, that's key to understand. We drive the requirements. In other words, folks don't come to us and say, hey, I got a great idea. We say, here's what we need. How can you help us solve it? Okay, and you're going to hear collectively from the entire panel for the next day how we've approached that. And then the military-specific medical education and training. I call that getting the product to market. And I learned this from our Joint Trauma System. We can have all the greatest ideas in the world. We can have the best clinical practice guidelines. But if you don't get them to the field and they don't become part of your, what I call baseline paradigm, okay, then you fail. So getting product to market. And that's where our big push is, and that's why we got Brigadier General Miller here today and Dr. Chip Rice to help talk about how, and we're going to need your help on this, how do we get the product to market. Next slide, please. Actually, back up one more. I'm sorry. Now, what I think is key here, look on the right. Look on the right. All right. So when those are our centers right now where we have military personnel embedded. Being trained in a programmatic fashion, not just the 1 or 2 what I call fellows going through there, but this is where we have military units actually embedded to where we have training programs. And so I think it's important that we have this relationship, and then what we're looking forward to, and we're going to talk about, expanding those opportunities out there, expanding those opportunities to more platforms so that we can get currency and competency that we need, again, to go out and do what our nation asks us to do. And I think it's going to be also interesting, and John, I know you're all over this, but it's what are your outcomes around those particular locations? Because those locations are also places where we've brought the lessons learned back from this conflict and rapidly infused them into the delivery of health care. In other words, putting tourniquets on your helicopters, putting blood products on your helicopters, using the clinical practice guidance that we have developed through our joint trauma system with the data registry to see how that's working in the civilian sector. And I know we're looking at initiatives, again, for studies between the military and the civilian sector. Next slide, please. Now, the mil to civ and the civilian to military, transfer of lessons learned. This is about the translation of military advances, okay, to the civilian community. That's where we are right now. But we're coming at the end of conflict, although I'm not so sure this conflict's going to end for a while. But then there's what we call the interwar years. And notice I didn't say peace, okay? There's the interwar years, all right? And that's where we reverse that, where, again, we have the translation of civilian advances, okay, to keep our military system sharp, honed, current, and competent. And then we showed on that other slide, and that's where, again, we are looking at you all to help us. How do we maintain those platforms? Okay, where do we get that currency competency to do what our nation asks us to do? Now, right there where it says no drift, that's an interesting editorial in a paper, and I think it's kind of probably time to foot stomp that. Almost throughout history, every time you come out of a war, what happens is you kind of drift back to status quo prior to the war. Okay, instead of keeping that machine that drove those advances, that enthusiasm, okay, that allowed us to advance in the war, and we kind of drift back. What we're trying to do now, and that's why again we are here, is to set the stage that there's no drift, okay? That we keep a steady course, okay? Where we have that translation between mil to civ and civ to mil. Keep up that enthusiasm, okay? Keep up that focus. Keep up that push so that we continue to bilaterally advance the health care, not only of the United States military, okay, but also of our nation. So that's key. Next slide. Now, this is just kind of you'd say this is pretty obvious, but it's been a while, and I think there's a couple of things that have happened that won't allow that drift. One is the enemy's decided to take the fight to our soil. Make no mistake, the enemy's decided to take the fight to our soil. So our vigilance is up, and I think our need is up. Okay. All right, so that is key. So we are, I think, going to pay attention. Two was the establishment of the Joint Trauma System, but also that we actually palmed for it and built it programmatically. So the Joint Trauma System is not only is it not going away, okay, it's now a designated center of excellence for the military healthcare system. So we've laid the foundation, okay, so that the drift is going to be minimal, I hope. But we need to continue, again, the support. Next slide. I also talk about the why not. We talked about the why not before, but that was what I call the quantity of life. We're saving lives at an unprecedented level. But what's just as important, and I would argue maybe even more important, is the quantity of life is important, but so is the quality of life. And I love to end using my comments with this picture because this shows that we have had the opportunity to focus on the quality of life. And again, I would argue 13 years ago, I'm not so sure we would have seen that scene on the left-hand side of this slide with a bilateral amputee, walking out of the hospital, with his family. And there's not going to be business as usual, but I can tell you it's going to be a whole lot more, what I call the normal activities of daily life are going to be a lot more normal than they would have been at the start of this conflict. So that's the end of my comments. I'm going to turn it over to Dr. Dave Smith. Thank you.
Well, thanks, General Robb and Chairman Berwick, Dr. Marcosi, and members of the committee. It's truly an honor also for me to be here today to discuss our critical and dynamic mission, if you will, to deliver optimal trauma care to anyone who passes through our doors. And the military health system has faced great challenges and also enjoyed great successes. And in pursuit of our operational mission, sharing with our civilian colleagues in forums like this today, what has worked, what has not worked, has also helped us and is one of our fundamental responsibilities as an organization committed to continuous learning and continuous improvement. Now, I'd like to build on General Robb's remarks as he's capably laid out the why and highlight how we are building on our successes and articulate the challenges we are facing and outline our path forward. Now, as General Robb noted, military trauma care looks vastly different today than it did 13 years ago or even 5 years ago. When we first entered Afghanistan and Iraq, we knew the kinds of injuries and challenges we could face, but understanding them theoretically and academically was very different than caring for them in theater. And some of those early lessons we had frankly learned before, but the lack of formal institutionalization of that knowledge led some of our skills to erode during the intervening war years during major conflicts. And another, perhaps more important factor has to do with the nature of war itself, that it evolves in unpredictable ways. Just think of improvised explosive devices as an example of that. So that, as much as we prepare for future conflicts, we need to be prepared to be continuously learning on day one. And the evolution of our trauma system from 2003 to today is a testament to this continuous learning system that we've talked about and put in place by our providers and medical professionals. And as Dr. Rob pointed out, clearly it was a grassroots from the ground initiative that ultimately ended up with what we have today. But if you consider the staples of combat casualty practices, for example, tourniquets, and remember at the beginning of the war, we didn't really have an effective tourniquet, and the tourniquets were considered an item of last resort. But we've clearly shown over the course of the 13 or 14 years of combat that that was not a correct principle, and that when properly trained, they are an incredibly effective tool. Or also think about hypothermia prevention in the desert, or hypovolemic resuscitation, proper blood component ratios in the administration of blood, and of course the joint trauma system. None of these were in place when Iraq and Afghanistan conflicts began. Now, as we look to the future, the advances we've made will only be as good as our ability to sustain them. And in that respect, we face two challenges. First, we are entering a period of lower combat levels and consequently much lower number of casualties. Now, make no mistake, this is great news. But I also want to make it clear that our current operational environment is not what we call peacetime, as General Rob pointed out, and there are active operations still taking place around the globe. But with the drawdown of forces in Iraq and Afghanistan means we need to keep the skills of our medical providers sharp and to prevent the experience that they have gained in the deployed environment from atrophying over time. And this experience is going to come from greater integration with our civilian health systems. Second, our interest in sharpening the skills of the entire clinical team, that is our interest, and we have 18, 19, 20-year-olds, medics and corpsmen who've gone through superb training and are very well equipped. And when a service member is wounded or injured far forward on the battlefield, they call these medics doc. And to the wounded and their compatriots, that's exactly what the medic acts as, and they're the true heroes of all of what you see in the improvements. And we clearly need to figure out and be able to maintain that capability and leverage that capability when they are back in CONUS. Now, add in the nurses, administrative staff, and other ancillary personnel, and we have to also ensure their experience gained on the battlefield is also sustained, and that our training programs ensure future medical personnel will meet the standard of care that all of our service members deserve. These challenges now drive a number of important initiatives from the Department of Defense, and leading this is the strategic initiatives is the institutionalization of the Joint Trauma System. And as I think most of you are aware, one component of that system is the established process that ensures data on every combat casualty is recorded, analyzed, and incorporated into a broad corpus of trauma care information accessible across the services. And this body of knowledge helps form the best practice guidelines that have allowed us to increase our survival rates, even in the face of increased injury survival, as we talked about earlier. And second, in order to maximize knowledge sharing on trauma care to the greatest possible extent, we need to forge new strategic partnerships and strengthen our existing ones with organizations in both the private sector and the federal government. And we've recently expanded our partnership with the American College of Surgeons, and I saw that you have David Holt on the agenda just after us. in order to accelerate sharing of our medical research portfolios, best clinical practices, and to develop even more training tools in the trauma arena. And we also have relationships with leading institutions like C-STARS at the University of Cincinnati Medical Center and Maryland Shock Trauma, allow military medical personnel to hone their skills while treating critical care patients in a civilian setting. And of course, we're constantly looking at ways to reimagine our partnership with the VA and to achieve greater efficiencies and outcomes, including how best to utilize the more than 200 hospitals that we have between our two organizations and care for the kinds of clinically complex patients that help prepare not only physicians, but our entire medical teams with the skills they will need on the battlefield. And third, we are modernizing our own infrastructure. We aim to place our medical personnel in communities where their clinical skills can be properly sustained. And where clinical skills cannot be sustained in the military hospitals, and where high-quality civilian health options are available, we are looking at greater partnerships with local civilian institutions. And as General Robb noted, our future focus is also directed at our education and training programs at premier military medical facilities such as the Uniformed Services University of the Health Sciences and the Medical Education Training Campus in San Antonio, continually improving our education methods, including field-specific trauma coursework and improved simulation platforms. Now, in a broad sense, the most fundamental challenge that DoD faces lies in understanding and continuously updating the essential capabilities that we must develop and maintain, not just to sustain skills for the most recent conflicts, but to anticipate what sorts of skills are required in the future conflicts. And some skills are applicable across the military and civilian medical spectrum, but there are also skills specific to military medicine and even to particular services. The challenges faced in operating in extreme settings, in the deployed environment, in air, undersea, require the department and individual medical departments to customize some of our training and develop unique partnerships that are aligned with these unique missions also. And finally, we view investments in medical research as critical to our continued advancement in trauma care. Our research investments have produced a number of innovative solutions and built upon lessons learned from our recent conflicts. And we're committed to continuing to share our findings as rapidly as possible to the rest of the American medical community. Now, DoD's Combat Casualty Care Research Program oversees a robust set of initiatives undertaken independently or in tandem with external institutions, but based on a set of requirements designed to close knowledge gaps. And our combat casualty care research is supplemented by additional relationships with leading academic research institutions on critical priorities such as traumatic brain injury, psychological health, extremity injuries, vision, hearing, and regenerative medicine. And increasing links between the military health system and our partners in the federal government has been a priority, particularly with the Veterans Administration and the National Institutes of Health, to allow us to focus intently and efficiently on our shared research priorities. So our future success will not be shaped from a purely internal perspective, nor do we want it to be. And the work we have undertaken with the National Academies of Medicine and the input from all of you here today will be critical to our future. And the outlets for pursuing our plans for greater military and civilian partnerships continue to grow. We are very proud of the achievements we've made thus far, but know that there is a great deal of future work that we need to do. And while we are motivated by our mission, the caring for the soldiers, the sailors, the airmen, the Marines, the Coast Guard, the allies, the coalition partners, and all who need our care, we're also motivated and heartened when we see stories about the value of military medical advances leading to saving lives in the civilian settings, whether it's in response to Congresswoman Gifford's mass casualty event or the Boston Marathon bombings. We know that military-civilian exchanges have made both our systems work better. And I'm honored to represent the Department of Defense here at this gathering with General Robb, and we're looking forward to discussion today and your thoughts on where else we might consider expanding our partnerships and bringing together our communities in an ongoing and fruitful exchange of information and ideas. And in particular, thank you for your time this morning and commitment to serve on the panel, and we welcome your comments and suggestions. Thanks.
Thank you both very much for the opening presentations. We have till 11:15 for opportunities for discussion and questions from the committee members. So I'd ask the committee members to put their card on the end if there's any comments or questions at this point. Don.
Thank you both so much for being here and for your terrific comments. I want to ask two quick questions. One is rather personal, and I hope I'm not out of bounds here, but we're interested in leadership. It's come up in our conversations right from the first minute of this committee's meeting. You two are leaders. You're trying to make better the systems we're responsible for commenting on. When you look in the mirror and you think of yourself as a person in your leadership role, trying to make improvement happen, what seems to you important about what you do, your behaviors, your tone, your investment of time? Can you just help us reflect on your personal leadership? That's one question. I'll ask a second one when you've commented.
Dave, I'll let you go first on that one.
I think it starts out with the being clear on what the why is. Why are we actually doing it? I think that's what motivates people more than the, if you will, the how and the what. And then also understanding, in large bureaucracies, what is your role relative to making that change? And in front of you, we represent, so I have the sort of policy side, and we can drive change across the entire department. But I think as a number of the members on the committee know and have had experience, that can be a bit like making sausage. And can take time, but it usually ends up being a tasty product, hopefully. And then General Robb certainly puts a lot of input into that policy, but also is the execution side of it and helps us with the oversight of that to make sure that the policies are actually then being applied and put down. So I can ramble for a long time, but I think the main point to leadership, I think, is clearly articulating the vision and the why of what we're doing, and that drives the buy-in from the team, if you will.
Can we put the why slide back up, please? In fact, we just leave it up. And I would echo Dr. Smith's comments, and if we can go back to the very first slide, the why, and folks ask why, why, well, both of us, both Dave and I, spent 30 plus years career in the military, and folks say, why do you stay in the military? And why do you get up each day and do what you do? And I think this is why. I mean, it's key. We have a very specific and I think focused mission, and that's to support the men and women who our nation asks that we put in harm's way, and to ensure that they have the opportunity to the greatest extent possible to return to their mothers or fathers, their sons or daughters, their brothers and sisters, their husbands or wives. I mean, that's the way it was when I was a young flight doc. And that was, my focus then was, operational support to the aviation and flying community. And each one of us has a personal story like that, is to ensure that our fighting force is medically ready, medically ready, and we have a trained, competent medical force to take care of those folks we ask to go in harm's way. And so that you start out at what we call it at the squadron level, and now both of us worked our way up through our respective services, but both of us had the opportunity, and I think that's what makes Dave and I a little bit more unique than many, if not most, of our senior military leaders, is the fact that we both were either drawn into or drawn up to the joint environment. And so our perspective is broader than a specific service. Both Dave and I served as the Joint Staff Surgeons. Both of us served as what we call combatant command surgeons, where we were in a joint environment for a geographical area. And so we see the opportunities, we see the power of of the respective elements of our military health system coming together, okay? Coming together in the next slide, okay? And if you ask, if you really think about it, is that right there? You know, there's a week's worth of discussions just to talk about how we got from the left side of that slide to the right side of that slide, or more, in all the elements that have come together, and so it's a belief in what we do. It's a service to our nation, and I have been drawn by the professionalism of our trauma community. Many of those leaders present and past are in this room today. And what I love about them, I mean, if you go back and you look at what the Joint Trauma System has done and what we've done this last conflict, you know, when you look at really Vietnam and the Gulf War, you know, our lethality rate was at about 25%. Okay, now it's less than 10. That's the largest drop in the history of recorded warfare ever, in the shortest amount of time. And it's because the folks, the leadership of the folks like, again, John Holcomb, and again, the folks out there, going across domains, you know, pre-hospital, hospital, en route care, getting out of your silos and working across what I call in the horizontal, bringing everybody together to make this happen. That's what gets me up every morning to come to work to support that. And now, you know that was well, actually 15% drop. You know, they're never, this group is, what I love about you all in this room, you're never, ever satisfied. Ever, which can sometimes be a pain, but I love it. Okay, I love it because you're going after a 0.5%. You're going after a 0.25%. You're going after a 1%. You know, and I said, look, you just nailed down 15%, the largest decrease in the lethality rate in history. Not good enough. You know, not good enough. So thank you. That's why I come to work again, because the men and women like you in this room, okay, that say, hey, you know, maybe we can help fly the top cover for that.
So I'm going to take facilitator prerogative, and then we'll jump to Bill, Sarah, Adil, and John. I appreciated the presentation today. Good capture of where we are, and I wanted to see where you think, if you could capture 2 pillars, because DoD is one of our customers for this product, for this report. Certainly, if they're one of our customers, they may be thinking, so how do we phrase the next 5 years, the next 10 years? What is the vision for Lieutenant General Robb, Rear Admiral David Smith? Where does that vision look like what's right look like for the trauma care system for DoD in 5 years? How does that blend and link with the learning health system, which needs to be further, I would assume, implemented, or DoD would not be coming to the table and asking IOM
Slide 8.
To give some recommendations?
Slide 8.
And then to follow on with that, obviously there are challenges with getting from where we are to where we need to be. Can you really capture, and with some specificity, the challenges, the chiasms, the gaps that we potentially can help you fill? Dave?
All right, well, I'll start again. I think part of it is this institutionalization that we're in the process of doing of the Joint Trauma System and its expansion in collaboration with the civilian community. We have one level 1 trauma center in our system, but clearly there is the intent, both from a research perspective and from a teaching perspective, to be able to make that a much wider, stronger partnership than what we have right now. And I think that's a clear goal and area that we need to be pushing. Certainly supported by improved education techniques with modeling and simulation, et cetera. So that would be one of the areas. The other thing that we're trying to codify and should codify is the ability to be able to collect the kinds of information that we have been able to do across the entire enterprise, and be able to leverage the experience that's going on in trauma, across the United States and the globe, I think, because I think the database that was set up with a number of the folks in this room has certainly shown the value of that. And in collaboration with the American College of Surgeons and some of the other capabilities that exist, I think we can continue to push the science and not just have to have incredible leaps during conflict. And personally, I think those would be incredible wins if we get to that point.
I would echo those comments, and I think what's key is to continue to support, basically avoid the no drift. I think that's key. I think we have the what we call the further expansion of the Joint Trauma System principles. Okay, we've got the foundation laid into it. I think internally, we need to continue to advocate that is not a service-specific entity, but a military health system, a joint system entity. And as such, I think we need to be focusing on resourcing it that way, what I call service neutral. So that's the system, the foundational element of it, which I think is key. But then the expansion of that, we have several things going on right now with our medical modernization study and also the recent benefits commission. But one of the things they pointed out again, and why we're here, is how do we maintain the currency competency to ensure that we have a medically ready force and a ready medical force for the future. All right, and so that's why the right side of the slide is important. I think it's to continue to sustain that, and I would argue expand that. One of our particular services is more invested in this than the other right now, and that's the United States Air Force. Okay, what I think we need to do is we need to get the United States Army and the United States Navy to expand, their resourcing in the support of these what we call these embedded trauma capabilities within their within civilian institutions, okay, and that continued partnership. And trust me, there is no shortage of you all raising your hand to be part of that, and it's going to be up to us to endorse and to continue to what I would call allow the services to further invest in that. And I think one of the other key areas is and again, we've already started to lay that framework coming out of again our joint program committees in research, but that is to start to aggregate our databases. Okay, we kind of prove the wealth with the joint trauma system on the trauma side, but within that database, there's the full spectrum, whether it's vision, whether it's hearing, whether it's polytrauma rehab, whether it's mental health. We need to bring all those databases together, I think, to again, what I would call almost the big data, and again, this is all going to take resources, timing, money, and drive. And then there's also, again, I know we're looking at prospective studies, okay, with that, but our continued, again, from our perspective, to support the what I call joining forces with the civilian sector, looking at prospectively on the research environment.
And if you could solve truncal hemorrhage, that would be a good thing to do in 5 years.
We'll put it on the list. Bill.
First of all, thank you very much for your comments, and not only that, for your leadership. It's been felt actually in the civilian community from both of your commands. I'm going to ask you a short question, and that is, from a policy perspective, what needs to be done or changed to accelerate the implementation of a learning system specifically for a readiness force for trauma and combat casualty care? What policy changes need to be done that would help you do?
Policy, Dave.
You're not off the hook, General.
No, I'm the requirements guy. I'm the requirements. He's the policy.
So we have a couple of things that are in progress. One is, and the policy nomenclature is we put out Department of Defense instructions. And we are in the process of doing one to do this institutionalization of the joint trauma system. And that's codifying what was put together over the war. General Robb already pointed out that it's been put into the program, if you will, so there are dollars that are dedicated to that. But there are a lot of pieces to it. That's where our clinical practice guidelines should be approved. Right now, they're actually approved at a much lower level in the organization, and to make them an enterprise-wide suggested set of practice patterns, we need to raise them to that level. They've been made the center of excellence for the DoD, so that's part of this. We also need to be more rigorous, in my opinion, as far as oversight of all of the training that goes into the from the TCCC that you are all presumably aware of, all the way through. That across the enterprise there is a set of standards, et cetera, which this joint trauma system would do. So that's one of them. The other thing that we're in the process of reviewing and modifying right now from an instruction point of view is the required education or training that is required pre-deployment. So we found over the course of time that there would be requirements the COCOM had to go into theater. You had to have X, Y, and Z. On the ground, that wasn't necessarily what had happened because of all of the pieces of putting it together. And so we are at least proposing at the DoD level that there would be requirements such as that everyone actually receives TCCC training. If you're not a medic, that you would actually get combat lifesaver training to make these part of the just core part of our DNA, if you will, for going forward. And I'll let General Robb talk for a minute, and I'll probably have other things.
No, you said you had another question for me, sir.
I think from a policy point of view, philosophically is readiness, and specifically trauma and combat casualty care, readiness. Is it at the highest or the best priority within the Department of Defense to help you initiate the changes that you see are necessary?
So I'm not real sure of the question, but I can tell you that we are using combat or trauma care as the what I call the lead vehicle to help transform the military health system state of readiness, and I use that because it's kind of an analogy. Even though we have to be prepared, our essential medical capabilities need to be a kind of a full spectrum, okay, of which probably the most labor intensive or visible, but also the one that requires the most training, okay, in other words, investment of resources, is the trauma piece of it, the pre-hospital, hospital, and in care. And so, but in military medicine, we respond to the full spectrum. You know, it's everything from what I would call the essential, but at times you would call it mundane, garrison care. Okay, so when you think about it, in other words, a medically ready force. In other words, a soldier, sailor, airman, marine needs to be a full-up round to go do what we ask him to do. Whether it's a peacekeeping or all the way to a full spectrum conflict, overt or covert. So that's a little easier to do, okay, because that's what we do each and every day in our community hospitals and our clinics across the nation. But then we also, but then as you start to slide through the full spectrum of delivery, we're also part of disaster response, of which some of disaster response, humanitarian response, some of it is trauma. But by the time you actually get there, most of the time it's a little bit more about helping build infrastructure and also responding to some of the basic, what I call the basic essential medical care for just sustainment in that environment. So and then you work your way to full spectrum combat. So but to drive that medically ready force, okay, but then importantly on our part, a ready medical force to do that, I think requires that we as an enterprise, because we showed in this conflict, okay, that the power of the Army, Navy, and the Air Force and the Marine Corps coming together from a medical response led, I would call, what I would call, not, through not necessarily the designated leaders, but what I would call the leaders of the communities of practice, okay, or the communities of interest. They're the ones that came together despite our stovepipes. Okay, despite our stovepipes. And so what I think we need to do from a policy perspective, and Dave talks about, is how do you, before it was Title X responsibilities. It's the Army, Navy, and Air Force's responsibility to make sure that they have medically ready medical forces. But what we've got to do now is to become a more effective, more efficient. That is a true statement. Okay, but why should we not work off common core platforms or common core capabilities or common core training requirements? And that's the hurdle that we're going through right now. And that's what the Defense Health Agency in partiality was stood up to do, was to help have that platform to where we drive, because the core, maybe I'm gonna pick a number, 80% of what we do each and every day in medicine across the three services is pretty much common. Okay, but then the execution of the mission in the Army environment, the Navy environment, the Marine environment, the Air Force environment is different. But I think moving towards that and then sustaining the Joint Trauma System as that example, because when we had pre-hospital, hospital, and en route care working in silos, and they were having incredible outcomes. But remember, that was the beginning of the curve. Okay, but then at the end of the curve, okay, was when again the Joint Trauma System started collaborating across, so that the pre-hospital guys say, hey, be ready, or the damage to resuscitation guys are telling the CCAT guys, hey, this is coming, and they were working across the domains, and that's how we rapidly advance. And so that proved that we have to have a common core and a common set of capabilities, and I think that's going to be the hard part, getting the services feeling that is entirely their responsibility, but for them to have a set of policy and requirements that'll help drive that. Dave?
But to talk a little bit more about that, we have now committed as a department and the services to develop what we are calling essential medical capabilities. And so what this is meant to do, but it's only starting, so we'll see where we end up, is to actually define what are those pieces on an individual basis that are required to make sure that we've got currency, that we actually are ready for the various components required, particularly for going forward. Now, we did a fair amount of work trying to see what American medicine does in that. And I will tell you, it is all over the map, and there isn't anything other than related to the initial training that at least I'm aware of. I mean, we've got credentialing and privileging, all those sorts of pieces. But this is we're forging a lot of new territory here in our minds, critical to this issue of making sure we have a ready medical force. And I think that will have profound advantages if we get to where we vision to be, which is to have clear, and the Air Force is actually further ahead than the other two services on this at this point, but that's what we're trying to do, is to actually be able to define and then be able to set up our training systems, our entire delivery care system, et cetera, to support that. And it's far wider than trauma. Trauma is one of the ones we're using because it's so important to the enterprise, obviously. But as General Robb noted, the vast majority of medicine that goes on in deployment is not trauma. And so we've got to have all the various components that are required to maintain that force that's medically ready and continues to be medically ready during deployment as part of that.
But it sets the tone. It sets the urgency, and I use my service as an example of the strategic bomber community. When you think about probably 99% of what we're actually ever going to use is conventional, but it's only 1%, if ever, but what drives the readiness, what drives the urgency is that 1%. It's that nuclear capability. And the same thing in Dave Smith's former service. When you think about, the fleet, 90% or more of the fleet, or the actual execution of strategic power is going to come off the conventional side. Okay, but it's that nuclear piece of it, that sense of urgency, the consequences if you don't get it right, okay, that helps drives that initiative. And I think that's kind of what the trauma is doing for us, is saying, hey, you know, this is a sense of urgency. You know, you get this right and everything else will flow. You know, everything else will fall into place after that.
I'm going to ask, we have less than 15 minutes to, and more than five questions. So ask for an abbreviated question with as much as we can an abbreviated answer. So I'm going to next turn it over to Sarah. Your card's down?
No, I'm
On deck. Got it. Understood. Sarah?
So my question is, you have both laid out a number of policy aims and policy challenges. What do you see as some of the barriers in both the military health system and the civilian health system to achieve those policy goals? And what might you see as some practical solutions for overcoming those barriers?
Well, I think both Dave and I somewhat alluded to that. I know I sure did. I think some of it is the cultural transformation of the autonomy of the services. Okay, you know, they have an organized, trained, and equipped mission. Okay, and they've done a heck of a job. But then it's always been you know, based on on their priorities, all right, which is exactly what you want to do for your force. But we showed in this conflict, okay, that in order for us to get the results that we have in the lowest lethality rate and the lowest disease non-battle rate in the history of recorded conflict, okay, the way we're able to do that is not because the services did it by themselves, it's because we did it what I call in the horizontal. Okay, and so what that's going to require, though, is I think for us to maintain that level, is that we don't automatically drift back to, okay, now services you know continue on your own, but for us to create a more joint requirement platform that the services then take and put their respective spin on it and go forward. I think that's the hard part. It's that healthy tension between joint and service autonomy. Dave, your thoughts on that?
Yeah, I absolutely agree. I think the other one that that drives us, of course, is efficiency and cost. And between conflicts, we tend to organize to do more of the beneficiary mission, if you will, because you know that's dollars in the bank, if you will, that we don't have to pay somebody else to do, and end up with you know, an enormous number of specialists that may not be what we need for deployment and the going forward part, but they're clearly needed for the beneficiary part. And so that's another, it's happened after each one of the conflicts, and I think that's a big hurdle, is how do we, and so part of how we're trying to work that is by defining these things and all. We think we can get much closer to being able to define the cost of readiness and then be able to make the argument about that, because we've never been able to do that as effectively as we should, to be able to make the arguments to be able to continue to drive the main reason why our healthcare system in the direct care side, in my opinion, exists. So.
And I want to just put a caution note out there. Some people would automatically jump to the conclusion, which may be right or may not be right, then why not just a joint medical command? Okay, and so the answer is maybe. Okay, and again, that was a discussion we had when we stood up the Defense Health Agency. Okay, was one of the alternatives was, do we do a joint medical command? Okay, or do we do a Defense Health Agency? And so there were a lot of reasons, again, from the department's perspective and from the services perspective, that we chose the Defense Health Agency. And I want to give you a lot of history because it'll help set the tone as for what may be one of your recommendations. One of the reasons, and again, it was pretty much the majority recommended this, but what this allowed us to do, 80% of actually 85% or more of the savings, okay, from a unified medical command come from shared services. In other words, standardization across the board. Which is de facto a Defense Health Agency. Okay. But what this has done, though, is it allows us to preserve, and I think this sometimes is lost, okay? It depends on what you can afford. It allows us to preserve the military unique relationship of the medical services, you know, to the Army, the Navy, the Air Force. Make no mistake, on execution, their missions are different. Inside the OR, you know, you take the gallbladder out the same, okay? But how you set that up and support that, you know, outside the OR is unique. And so I think that is key and essential. And I would also argue, in one of our former Chairman of Joint Chiefs of Staff says, one of our strengths of our military, okay, is the diversity of the cultures, okay? Okay, I'm talking about Army culture, Navy culture, Air Force culture, and Marine culture. That is part of our strengths. Because if we were all like the Army, or all like the Navy, or all like the Air Force, or like the Marines, I don't think we would be as strong. Just like America's strong because of the diversity of cultures that we're here. So I share that with you to be careful about jumping too far to a conclusion. But how do we take the environment and get in what I call find that sweet spot, and get the best of both worlds?
Thank you very much for your comments, particularly your comments about leadership. In the civilian world, we have been talking about the lack of a federal agency that owns trauma. We have professional organizations like the AAST, several presidents of that organization in the room, including current president, Dr. Scalia, or the American College of Surgeons Committee on Trauma, which provide leadership. But who do you see as a federal partner? And should there be one? And if there shouldn't be one, then who should it be?
Well, I can tell you who we do partner with. And so the Department of Homeland Security, HHS, because of primarily the NIH connections. But your point's well taken.
Go to slide 8 again. I think it just timed out. That's a good question. And so slide 8, which is the map. It's the question is I think that's on the right there. You got the seeds for what you're talking about right there. You know, and you know who's got the lead, but I would argue we are stepping out in creating an environment to lead the strategic partnerships between the Department of Defense. There's a de facto almost military medicine department inside of Baltimore Shock Trauma. There's a de facto Department of Military Medicine inside the University of Cincinnati. Same thing at the University of there in St. Louis, and then again, the strategic alliance between the University of Texas San Antonio, Brooke Army Med Center, what used to be Wilford Hall, now SAMC, and then Houston. So you're seeing this kind of a grassroots, what I would call a network of leadership out there, and that, that to me is the seeds. Now the question is, where does that grow? Who should you partner with? Well, I can tell you, we're already partnered. Okay, we're partnering with the Department of Defense, with the American College of Surgeons writ large, okay? And then again, your participation and vice versa, again, in the pre-hospital, hospital, and the root care. So I think right now we're it for lack of a tag unofficially. The question is, Dave can address, where ought to be officially.
Well, and I guess I'm going to throw it back of why and what are we trying to accomplish?
Like, should there be one federal agency, in your opinion, that should be charged with coordinating trauma across the country from the civilian sector?
Okay, this is the difference between trauma. Okay, I thought you meant how do we advance trauma care. I think this is the foundation for helping us that mutual translation.
I'm talking about a national trauma. I'm talking about a national trauma system.
Yeah, and you mean like other countries? You mean like that? That's
well, that's honestly, I don't think I'm qualified.
No, I don't. Yeah, I don't know.
I think that's something that we need to talk to this to the societies and to figure it out and what we think that would help us with. I will tell you that DHS has clearly taken it and primarily is helping lead from, the emergency response point of view, et cetera.
I'm going to interject I'm going to try and move us along to make sure we all have representative time. John, you're on, and Ellen, you're on deck.
Sure, thank you for coming to this panel. I got 2 questions for you. I've heard actually maybe 2.5. Policy and requirements. What about implementation? How do you write policy, you make vision, you have great meetings, you say great words, and General Rob's comment, we're never satisfied with anything.
It's about getting product to market.
Get it done.
Getting the product to
How
market.
do you make sure you get it done?
Okay, so you're right, and you live that dream because we basically had to shop the joint trauma system door to door every time we had a major rotation going out. Okay, so what you do is you got to get it back in. You got to back it into the baseline. In other words, it's part of the core curriculum. That's what Brigadier General Miller is going to talk about this afternoon. In other words, we never had, in other words, in the olden days, when John Holcomb was on active duty, okay, we never had, we didn't have this thing called the Defense Health Agency. So now we have a joint entity, okay, that over time is going to become the conduit for getting I believe, to get the product. That's why the Centers of Excellence for Vision, Hearing, Joint Trauma Center, Psychological Health, which are currently being sponsored right now and hosted by services, are going to migrate towards this joint platform. And then they become the MHS Center of Excellence that push out through the authorities of the Assistant Secretary of Defense, Dr. Woodson. Yes.
Okay, so next question is the 75th Ranger Regiment at the very beginning of the war said medical care is equivalent to shooting. We haven't talked about combatant commanders at all in this discussion of military leadership. How have you made your combatant commander equivalents and senior officers implement that concept from top down and bottom up throughout the combatant commands?
So that's part of the reason why we've got these Department of Defense instructions to actually make those things requirements, which we did not have previously.
Can I ask a follow-on question to that? How do you measure whether it's actually been done after you write
and
that
that's
LOI?
where the oversight comes into it. And first you got to have the requirement to then be able to see whether the requirement is being. But the other part of it is making sure that it's part of the DNA and the instruction that goes along the way. Absolutely. I know exactly the question you're asking, and that is what we are trying to, the nut we are trying to crack, but it's got to start with there's a requirement to actually do it.
Right. And we're using the joint trauma system as a lead for that, and that's key because when before it was, oh, that's a U.S. Central Command thing,
right,
or that's an Army thing. Well, now that there's Center of Excellence for the MHS, now it's an MHS thing, and then now what we're starting to seed, another combatant command, PACOM, is standing up a joint trauma system entity, just like CENTCOM does.
So that leads to my last question that's going to be very brief. In a transparency point of view, when a good and a bad thing happens in AFRICOM, PACOM, non-CENTCOM, how does the leadership understand that those things are happening and translate that information across all of the COCOMs?
Well, again, I think that's part of the work of the joint trauma system and its maturation, if you will. Captain Retired Butler is here that has a pretty extensive network that we try to socialize. There's the weekly teleconferences of the combat casualties, another way that we socialize. And if there is clearly something that appears to have either been the rules were followed but it didn't go well, then we assess it that way. But if it's clearly out of the norm, that's where the Joint Staff Surgeon, and the COCOM Surgeons Network is another place where we can socialize. But you're raising an issue that we clearly can use hope with, which is that this is a very complex organization, and so how do you communicate those things?
You start feeding the database with exactly what you're talking about, so that we can do the continuous process improvement.
It's fundamental to a learning organization, right?
Yes.
It's fundamental. It's a I think this is a fundamental question, and sir, as you know, socialization's great, but you got to get it down. If there's a tourniquet problem in AFRICOM,
Yep.
you're right. Tourniquets in CENTCOM, they got it. But in AFRICOM, how do they get it? And when a bad outcome happens, how do you get that information down? Not both up to the leaders, but also down to the action guys on the ground.
Dr. Holcomb, I'm going to take a strategic pause, move over to Ellen for a question.
This is the one we really worry about since she's been in the seat.
Yeah. So this is actually for both of you, but primarily for General Robb. So DHA is the combat support agency for the military health system, as I understand it. And when we talk about leadership, we talk about the strength and commitment behind a mission and a vision. We talk about their authority to execute that vision and the funding to support it. So as the current leader for the Defense Health Agency as a combat support activity, what is the role of DHA in setting up this system, the vision system? What do you see DHA doing as a combat support agency to realize that vision? I see your 3 points here, which is what we have been doing, but I'd like a little more specifics on, you know, as a leader, how do we take the person who follows you to task?
Okay. So it's a very broad term, combat support agency, but to kind of set the stage real quick, because it's as we mature into our capabilities, number one at month 22, is we are going to be to Defense Health Agency is going to be to medicine or medical, as the Defense Logistics Agency is to the logistics world, okay? Or the Defense Information Systems, DISA agency, is to the communications world, okay? And so for the fundamental reasons that they were stood up for again, decreased redundancy, increased standardization, interoperability, increased effectiveness, increased efficiency, and at the end of the day ought to save you some dollars, okay? That's the guiding principles, again across the whole domain. You know, we have 10 domains we're working on right now, one of which, of course, is of which the joint, what we're talking about here is nested inside the clinical ops. Now, what we didn't have before is we didn't have a centralized joint platform to drive that. And so there's so many moving pieces here, and many of them these bricks are being laid as we speak, okay? And that was moving from a CENTCOM thing to an Army thing to now a military health system thing. And so it goes back to the says who. What you're telling me is the service, what they will tell you, says who, okay? You know, I got the Title 10, organized, train, and equip, says who, all right? And so that's what we're driving toward. We're driving towards bringing the centers of excellence, the military health system centers of excellence, of which the Joint Trauma System is one of them, bringing them into this joint domain called the Defense Health Agency. Woodson designated that individual as the one who's the head of that to be the speaker for that domain, okay? And then that becomes the says who. Okay, so those pieces, now it's not going to happen overnight. We have moved those pieces. You need the policy that says who. Woodson says who. Dr. Woodson says who. This is who's going to speak for the trauma community. So those bricks are being laid. And then it's going to be a while, okay, as that starts to mature. But we're seeing it because PACOM wants one. AFRICOM wants one, okay? And then we're going to start seeing, you got Brigadier General Miller say, hey, I got to start teaching tactical combat casualty care as a core curriculum standardized across the 3 services, okay? Services, hey, it's Title 10 organized training, but he's saying, no, this is that important. So we're driving towards that. The pieces are in places, the vehicles are in places, okay? Not going to happen overnight. The services are seeing the value in that, but I think we have many of again, the bricks are being laid. The concrete is not yet cured on the rebar, okay? But we're well on our way.
So we are already over time, so I'm going to turn to Philip for the last question. I'm just going to ask our civilian sector panel to get ready to send, because we're actually going to make the switch. There's no break. We'll move right into the civilian sector. So, Philip.
Thank you. I'll be brief. This follows up on some of the recent questions. What is your vision for the leadership structure that keeps the medical infrastructure accountable to compliance to the guidelines or requirements as you've called them? I mean, it's been fascinating that our outcomes have been so great without really keeping the troops accountable to the requirements or guidelines that we've developed so far. I think that's when people talk about who owns trauma medicine, that's what many of us mean. Who is going to keep us, or the troops, accountable to the requirements? At least from my perspective and my experience, if there aren't consequences for non-compliance, it's very difficult to gain complete compliance. And we know from TCCC meetings there is non-compliance out there, so we can do better. And even from my pediatric critical care experience in the military, when we keep our parents accountable to bringing their children in for immunizations and asthma clinics and diabetes clinics, those diseases melt away. We have the ability in the military to keep people accountable, much easier than that can be done in the civilian world. So what's your vision for a leadership structure, top down, not bottom up? I hear the bottom up argument, but what about top down?
I would suggest it's it's a lot of what we've laid out, which is the fact that we've got to have a requirement to then judge by. The oversight of the policies clearly rests directly with Health Affairs. And I think it's going to be a matter of, and then we basically will use the DHA as our arms and fingers and hands to actually judge whether or not it's being complied with or not, by going to the services and say, okay, show us the goods. We get plenty of feedback from the field to tell us when and when it's not in compliance. And I'll just be frank with when it's clear lifesaver, we haven't had the compliance problems that we've had when after that's been shown through evidence. Recognizing that it takes time also to get things translated to the field. So a good example is junctional tourniquets. Those were developed and fielded about 2 years ago. We're still in the process of trying to make sure that those are available everywhere they need to be. And so certainly suggestions and ideas of how we can speed and make sure that those things occur would be welcome. But the reality is that's what we're trying to set up by institutionalizing all these pieces and making it, again, part of our DNA.
And what we didn't have before was and this is I use education and training because that's somewhat part of the paradigm here, but also our medical operations clinical support division. Before, what you had is, you had you had to go to 4 outboxes, and then each individual service was kind of up their own to decide. What you've got now is, and that's why I think it's important, and shouldn't be lost on you, the fact that we made the Joint Trauma System the military health system, not the Armies, not the Navies, not the Air Forces, and not the Marines Joint Trauma System, but the military health systems Joint Trauma System. Okay, all right. Then that's going to be what I call the keeper of the scrolls. That's the keeper of the scrolls. Okay, who's going to keep the pot of light burning in the interwar years? Okay, that's who it's going to be. All right. And then what you've got, what we didn't have before, is we didn't have a military education and training directorate that has a direct feed into the schoolhouses that will then work those issues, Title X responsibilities, in getting in the curriculum. So you're seeing these communities of interest that are coalesced around, again, I use education training as probably a key. Research and development, okay, now the core, the joint medical groups there are actually now going to be in the Defense Health Agency, not in the Army, okay, but in the Defense Health Agency. So now we're going to be able to, what I call the flash to bang, we hope will be shorter. Okay, getting the product to market, we hope, will be shorter. Okay, our first success was, although it took a while, but it was facilitated at the end, a logistical piece of it, the joint first aid kit. Okay, We saw some rapid advances when we got the logistics piece of the Defense Health Agency sponsoring that at the end. And again, it was a long road, but it was shortened, okay, because we had this thing called. So you've got all these pieces, the logistical piece, the education and training, the research and development, standardized clinical ops coming out of the, all these pieces in the Defense Health Agency that, again, over time, we believe will become the conduit, just like in the logistics community, just like in the intelligence community, just like in the information systems community.
So I want to thank Lieutenant General Robb and Rear Admiral Smith for your presentations today. I'm going to call an audible with the chair's prerogative. So here's the audible for the committee. We're going to shift from an 11:30 to 12:15 discussion for the civilian sector panel, a 12:15 to 1 o'clock discussion, which will allow the same amount of time from our military side to our civilian side, and then shorten our lunch from 1 o'clock to 1:30, so our committee will only have 30 minutes for lunch. Apologies right now, but I'll take the facilitator's prerogative on that. So I'll ask for a switch out to our civilian sector.
Thank you, John.
And during that time, I'm actually going to make introductions to be able to facilitate an expeditious presentation. So, for our civilian sector panel, I'm honored to present the Executive Director of the American College of Surgeons, Dr. David Hoyt, the President of the National Association of State EMS Officials, Mr. Paul Patrick, the Director of Trauma and Emergency Medicine, and Vice President of Academic Affairs and Chief Academic Officer at Hartford Hospital, Dr. Lemworth Jacobs, and then finally, the Director of the Emergency Care Coordination Center at the Department of Health and Human Services, Dr. Brendan Carr. So thank you all very much for your presentations today. Dr. Hoyt, I'll turn it over to you for your first presentation.
Great, thank you, and thank you for the opportunity to be with you this morning. You have the slides up, please. What I decided to do was to directly respond to the questions that were put forth, realizing that we'll have more time for discussion. So question one was really, what is our vision for an optimal care system, trauma care system in the United States? And we have a large basis for this. The history is rich. Perhaps the first to allude to the need for this was Herbert Hoover. He was a management engineer really by trade and helped rebuild Europe after World War I. And when he was Secretary of Commerce, called for a response to the epidemic of mortality, automobile mortality in the 20s. In that law that came forth, that really is the basis of everything that we do today, there was really no call for care system. So from the beginning, we were really behind in this. It was really perhaps in this room 60 or 50 years ago that this document, which I'll point out was 18 pages, the ACA was I think 20,000 pages. This document was 18 pages, which really created the declaration that this is a neglected epidemic, and everything has really flown over the last 50 years. Now, the image, the vision that the American College of Surgeons has participated in putting forth really goes back to this image of a coordinated approach, swift identification of injured patients, and transport to optimal care. So the right place at the right time for the right patient was really the image. The other two portions of this, prevention and then sort of the acute care research agenda, were imagined at the beginning, but the focus initially was really on the development of the infrastructure. The model used at the time was a public-private partnership, and I think that's very important for this group to consider going forward, and what that actually means, what are the implications for that, how do you govern that kind of relationship, and then really the standard public health model of assessment, policy development, and assurance was developed. What we have based on that after 25 years or so of working on this is really a model that the college uses for everything we do in healthcare, whether it's bariatric surgery or general surgery, NSQIP, some of the programs that we've developed in the last several years. Most of these were based upon the principles we learned in the trauma model, and that there's a four-step process. One is to set standards, write them down, agree with them. When there's evidence, use evidence to support them. If not, then consensus. build out the infrastructure to actually deliver and operationalize that model. The third is from the beginning, create assessment tools and databases to measure performance so you can constantly improve the system. And then fourth and final, provide external peer-reviewed verification. So that four-part model has really been behind the development of trauma systems in the United States. It includes all the elements of paramedic training, regionalization of EMS systems, access through development of 9/11 systems, ATLS standard protocols for initial treatment, trauma care standards, which are really define how a trauma center is operationalized, the verification process, how do you go through that, and then the original National Trauma Data Bank, which you'll hear later today is now a program called TQIP. I would argue, and when we discuss sort of the origins of the ACA and what we're trying to do with that this model truly is a population disease management model that is payer blind. It's not perfect, we're not there all the way, but to me it remains a prototype for how I think about what we're trying to strive for in this healthcare system in the United States. Now, what's the results? As a result of this, we have a distribution of trauma centers, which you can see in that map in the upper part of the slide. And what that translates to, and a lot of this work has been done by Ellen McKinsey and her associates, Bill Schwab, et cetera, but we can demonstrate that there is access to a trauma center in this country within 50 miles for about 80% of the country. Again, not perfect, but significantly different than even 20 years ago. What it means in terms of actual mortality reduction, and there was a consensus conference about almost 20 years ago, so-called the Scandinavia Conference, which is about to be repeated, but that demonstrated that about 8 to 10% mortality reduction was possible using all techniques. Now, the more definitive study, again, it was Ellen's study from 2006, which demonstrated perhaps as much as a 25% mortality reduction. And what you can see from that graph on the left is this is directly proportional in trauma deaths to the availability of a trauma center. So where in the country there's a lower density of trauma capability, the mortality rate is up. And that's a correlation that's been shown over and over again. So trauma systems do work, they can be built, and that's sort of where we are today. Now, who controls or drives trauma capabilities? And again, this is a big question. You were just discussing a lot of this. The original criteria to define what a trauma hospital and a trauma system were really go back to about 30 years ago with West and Bozzoli. They created 8 criteria. When this was measured in 2001 in terms of how many states could actually achieve that, it was about 50%. Progress has been made since that time, but this was really the basis of trying to measure whether there's a full trauma system in existence. One of the problems you can see from Maryland on this slide and then California, these are regionalized and the authority is basically a state or a county government. In California, it's ceded to the county. In Maryland, it's overseen by the state. So the gaps that you might incur are really because of this decision-making about who the authority is. And again, the question you were just examining about who is accountable, who does have the authority, remains an important one today. In 2006, a revision of the trauma model was undertaken by HRSA, and again, with collaboration with the college and many others, the Model Trauma Planning and Evaluation tool was created. And this is now the standard tool that's used for most systems going forward and has been for the last 10 years. We have a consultative program that we've offered for almost 30 years, which goes in with a team, helps a state or a region try and define where they are relative to these standards, and then tries to help them create a plan. And you can see that over the last 15, 20 years, we've really been to most states and have significantly contributed in moving this agenda forward. So to your question of how to operationalize this, I think this is one process that has to be continually considered. How does it stand up over time? This is a study that was just completed by the Committee on Trauma this last year and just published, and they studied basically the durability of these sustaining elements for a trauma system over a 3 to 9 year period of time, looked at 20 systems, and this is their results. So about 11 of them were able to sustain or improve over time, and about 6 of them either stayed the same or deteriorated. So the message here is you really have to reinvest in this continuously to maintain a state of readiness. Question 3, what are the actions that can be taken to translate the military lessons into the civilian sector and vice versa? And again, this is something that we've spent a lot of time doing over the last couple of years. The first is really, has already been alluded to, is a partnership that we established this last October. Here's Dr. Woodson and I signing that document. And what it really puts forth is the opportunity to partner with the Department of Defense on these 4 areas. Quality collaborative, so perhaps, I mean, our vision there would be to create a learning collaborative for all the Department of Defense hospitals, perhaps including the VA, and use the principles that we've learned in programs like NSQIP, et cetera, to not only deal with in combat readiness, but how do you sustain the hospital system between conflicts. Education and readiness, that's been alluded to. We have a lot of rich opportunities in the college that we can collaborate with, and we're going to work together on that. The Joint Trauma System has been alluded to. What we're planning to do with that is to undergo a formal assessment with the Department of Defense, with the Joint Trauma System document, and try and actually see what can be implemented. And then finally, how do you actually create an infrastructure for clinical trials using either clinical registries, now that those are much better, and trauma hospital networks, and we have some experience with that. John Holcomb and I, almost 15 years ago, collaborated with the NIH, created a visioning process, which ultimately led to an RFA that led to this network known as ROC. It has about 24 million lives in the United States touched, so perhaps 7 to 10% of the population. And with that and $85 million over the last 11 years, these kinds of resuscitation protocols have been subjected to prospective randomized trials. So this is possible. This model per se is going to sundown, but it gives us the infrastructure and the knowledge to understand how to do this so you can test a hypothesis relevant to the military in between conflict in the civilian sector. And we have real data showing that we can actually do that. I'll skip over this. Len's going to talk about another implementation strategy, but how do you take the concept of tourniquets and making them available and make this a public health issue? And we've collaborated with the military under Len's leadership to create the so-called Hartford Consensus, which again is an example of getting something out there and operationalizing it. Fourth question, what's going on relative to the ACA? And I would say that the best way to approach this is what is currently in the legislative pipeline. And we don't have time to go through this morning, but I thought just for your information, I'd put together, there are currently four House bills that are looking at this. The first one is really to create federal funding to help cover uncompensated costs in trauma centers to maintain the system in the United States. The second reauthorizes the trauma care planning grants to really finish the system out. And then there are a couple there aimed at disaster management and EMTALA violations, providing liability protection to all providers for those. So those are some examples of how federal legislation can be used. Finally, the college is a leading national effort in creating infrastructure. What should be done to build on this capacity? And our list would really be to complete the system with some kind of federal oversight. I think the conversation you were having in the last panel is very, very important. I don't know that we know the answer, but I think pushing to get an answer that would allow more accountability for this over time would be important. The matching grant thing has worked. I think that's how the federal highway system in this country was built. I think it's helped build a trauma system. It might be one model. Utilizing the ACS consultative expertise, again, we have a lot of data to suggest that that kind of process is very effective in bringing systems along, and I would encourage continuing that. I think we need to deal with something that's new, and that's get to vulnerable areas and create a set of criteria that are needs-based designation process. We've avoided that historically. It's led to over-designation in some areas with the growth of the large conglomerates of hospitals, et cetera. They are starting to sort of declare their importance in deciding how hospitals are designated, and I think that's a real threat to these kinds of systems if we're not careful. And then finally, I would really emphasize better learning and articulation of what we actually mean by shared governance in a private-public partnership. My own experience with that in a system in one part of the state of California was a very, very positive experience, and it has a lot to do with how you set the cultural expectations, how you create mutual respect between government and the private sector, and I think it really is an important model. I'll just end with suggesting that we are going to have a follow-up conference talking about how to complete the U.S. system, and that's going to occur in August. So again, thank you very much for the opportunity to be with you today.
Thank you, Dr. Hoyt. Just a reminder of the following speakers. As soon as my card goes up, I've given carte blanche to come up there and strong arm all of you. So as the card comes up, that will be the time. It's approximately 10 minutes. Mr. Petra.
So I will look right at the card. Anyway, it's a privilege to be here. As a representative of the National Association of State EMS Officials, my vision of a trauma center is somewhat focused on state and territory, since that's the responsibility of our association. And there are three things that directly influence my vision. The first one is the safety of pre-hospital providers, regardless of their mode of transportation to a trauma scene, whether it be ground, water, or air. The second one is to provide optimal care to the trauma patient, utilizing the most current and validated equipment and procedures. And that's where a lot of what the military is doing now becomes a huge role in what we adopt, accept, or utilize in a pre-hospital care environment. And the third one that influences my vision is making certain there is expedited transport to the appropriate trauma center, and also proper and timely notification from wherever that, let's call it the scene, is to the destination. My vision also includes guidelines and protocols driven, locally adopted, and approved by the state EMS office and adopted by local medical control. And I think those are key to a true trauma system that will work. I believe that the second part, and I'm kind of following along with the questions that we were presented with. I believe trauma care capabilities at the trauma level systems are controlled by local responders, local governments. I'd originally put down local hospital corporations, but more recently with some activities, I think I have to maybe extend that to hospital corporations, because a lot of times the national corporations are driving that, and local medical control. Through input and national guidelines established by the ACS and adopted by states is another important part of the drivers, but the main driver has to be locally. Unless there's a local advocate, the system will not be successful. Success has been and is possible because of the past and continued support from the NHTSA's Office of EMS, led by Mr. Drew Dawson. I think one of the best ways to expand advocacy, though, is through NASEMSO and our Trauma Managers Council that is associated with most, if not all, of the state EMS offices. And the cost of trauma is a huge factor that most often drives the process. Relative to the transition to the military, lessons learned to the civilian sector, I feel the key is education. That was mentioned a little bit in by the previous panel, the importance of education and training. But I believe it's important at the pre-hospital level and the adoption of then approved guidelines and protocols. We need to teach the best lessons learned from the military actions that they take on the ground for traumatic injuries. I think that's why NASEMSO plays a vital role in getting the lessons learned to the pre-hospital personnel, because our member states and territories license those pre-hospital personnel and also are responsible for approving their training and recertification as well as certification. With the adoption and use of the approved education, clinical guidelines, and local protocols, these lessons learned can be easily transferred to our EMS community. The big one, to me, is the last one. Where is trauma care in the context of health reform? Does trauma care get integrated into health delivery reform process? I think it is probably a forgotten or potentially overlooked part of health reform. The bills that were recently just barely identified are critical, but since trauma care is now a cost primarily paid by third-party payers, if the reimbursements are extremely limited or cut by health reform, the cost paid to the providers for trauma care will be decreased. Some states pay for trauma, but a recent Western state magically over a weekend cut that funding by 50%. And that state had to, because it was through a balancing effort through a state health department, so that state had to pull back funds that were allocated for trauma delivery of services. I worry that that might become a repeated practice, that we'll see a shifting of trauma costs to insurance companies. And with the onset of health reform and without a trauma authorization at the federal level, trauma care payments may become exempted from reimbursement, adding to the burden of uncompensated health care. So those are my concerns. The tent did not go up, so I've probably saved the rest of you some time, and I will turn it over to you, Doc.
Good morning. My name is Lenworth Jacobs. It's a privilege to address the group on an important issue: optimal trauma care for the citizens of the United States. The vision for an optimal trauma system is complete access for all trauma patients to optimal trauma care in the United States. There are two critical concepts. The first is access, and the second is optimal care. As David mentioned, the American College of Surgeons has defined optimal care in a number of published documents. They form the basis for certification at the Trauma Center Level 1 through 4. Once verified by the American College of Surgeons, a number of states have utilized these criteria to designate trauma centers within their states. There are also criteria for trauma systems, which have been spelled out in written documents. A number of states have been reviewed by the American College of Surgeons and other federal agencies to codify not only the elements of the system, but the degree to which they comply with the optimal system of care. Finally, a number of states have adopted regulations or trauma laws which define the standards to which pre-hospital and hospital personnel and facilities are expected to perform to provide optimal care. These regulations or laws are codified and therefore can be regulated by the Department of Public Health. The optimal care document outlines clinical competence, availability requirements, an organizational structure, standard by which the facility is required to perform. There's an evaluation component which measures compliance of the facility and its personnel with these levels of trauma requirements. In general, these criteria have assured a system of trauma care which is functional within the United States. The second critical component is more complex. That is access to the system and access to optimal clinical care by providers within the system. In general, access is significantly dependent on payment systems. These systems may be private or governmental. They are usually specific to an individual patient and require some kind of insurance to assure optimal care. A number of hospitals provide free care on an emergency basis, but once the emergency has been managed, the optimal long-term care is not assured. A number of problems exist with these systems. Both hospitals and individual practitioners have, on occasion, attempted to maximize payment from these various systems. There are examples where hospitals are within systems that have attempted to provide optimal care for some patients within the system, but not to all patients. This severely affects access. This problem can and does result in a two-tiered system of care. This stratification can be seen in the management of blunt and penetrating trauma, since these two types of trauma events frequently have different payment mechanisms. A critical issue is to decide whether trauma care should rise to the level of a public safety model, such as fire or police. There is an expectation of the public that their fire or police services will be provided regardless of payment source. This has resulted in either governmental compensation systems or private systems. However, the public is assured of 24/7 fire police services. Once a compensation system has been established, it is critical to establish who is the responsible fiduciary agent. Is this a governmental body, a hospital, a university, a group, or individuals? There should be some standard across the geographic region which the system represents. Another really critical question is how this model will change when the compensation system changes from a fee-for-service model, which is generally driven to the individual, to a value-oriented population-based model, which is driven to the population. It is critical that some entity who is competent and without bias should determine the compensation, the rules of performance, and the evaluation of the system. Solutions. Medical practitioners are increasingly incurring significant debt in their training, some as many as hundreds of thousands of dollars. Practitioners who need to resolve large loans feel the need to pursue specialties which allow them to address these liabilities. This is a detriment to pursuing trauma critical care careers, especially for those practitioners who wish to pursue careers in underserved areas with high volumes of trauma patients who may have inadequate insurance or compensation schemes. There should be a loan forgiveness program on a year-for-service basis if the practitioner practices in an underserved area. Compensation should be linked to service needs or system integration. Malpractice premiums, which can be as high as $100,000 or more, should be discounted for care given within a specified system. Military lessons translated to the civilian sector. A committee was established to establish a national policy to increase survival from active shooter and intentional mass casualty events. This produced a series of documents called the Hartford Consensus. We're privileged to have a number of people in this room who were involved. General Woodson, Dr. Holcomb, Dr. Butler, Dr. Scalia, and Mr. Serino. These documents outline in detail the need to establish a coordinated, comprehensive response that can function in an urban, suburban, or rural environment on a 27 basis. The committee was formed to be collaborative with medical, military, the National Security Council, the FBI, Homeland Security, FEMA, law enforcement, fire, EMS, and the pre-hospital and hospital community. Part of what national security wanted was to have the citizens become immediate responders. Specifically, if an event went on in this room right now, we would be the immediate responders, and we would be empowered to give care, to stop bleeding. We should have the education for it, the empowerment to do it, the equipment to do it. That would be the vision, because unfortunately, these events are happening everywhere. It used to be only in highly specified places, but now it could be a church. It could be a hospital. It could be a university. It could be a governmental agency. And it has been all of those things. The goal is to empower the citizens in the same way that if someone arrests, you do CPR, or if you're choking, you do a Heimlich maneuver. The other component for this is that simulation to develop and maintain competence both for the individual and the team, should be implemented widely throughout the United States. It is clear there's a rapid and increasing change from individual practitioner and individual hospital to the development and enhancement of groups of practitioners and hospital systems. Another major change is the establishment of large electronic health records. These changes have established opportunities to inform a national trauma data bank, which is population-based and nationwide. A strong recommendation would be to customize and integrate an electronic health record to include trauma registries and to develop severity-adjusted data which can be used for comparative purposes. This will quickly identify best practices. Compensation should be used to enhance these kinds of severity-adjusted, disease-specific registries. Finally, prevention strategies should be integrated into the trauma healthcare delivery systems, and compensation should be attached to these strategies to enhance positive results from their rapid integration into the healthcare system. I want to thank you for the opportunity to present these thoughts and ideas to the committee.
Hi, everyone. My name is Brendan Carr. I'm from Health and Human Services, the Emergency Care Coordination Center. Thank you so much for the opportunity to be here today. This room is full of many, many leaders in trauma emergency care, certainly mentors to me. Thank you very much. And although others didn't do it, I'm going to take 30 seconds to just sort of say that I think I approach this from a little bit of a different frame. My training is in emergency medicine, followed by trauma and surgical critical care. Dr. Schwab was kind enough to train me in that, followed by a health policy research fellowship. So my career development award, I started, my life before government was in academia, was in trauma systems, but candidly, I've taken more money about stroke system development now than I have about trauma system development. So I bring an agnostic or relatively agnostic approach to system design, and you'll see that reflected in some of my comments. If people are in need of a system to respond to their needs rather than their own decision making, I think that we bridge into what is a public good, and I think that we can learn a lot of lessons as we crosstalk across diseases. Did that go? So I just want to remind this committee, and I know that many in this room wrote these words, and I'm grateful for them, but this report, which I'm sure you all know from June 2006, essentially said, that a lead agency was needed to do a lot of the work that's being done here, or a lot of the work that's being discussed here. And the 2006 reports were followed by a presidential directive in 2007, and then the development of the office that I now direct in 2009. It's important to say there are people in this room that helped to write that presidential directive and make this happen. It's also important to say that this is not an agency, the CCC, and this request was to Congress, and this is a presidential directive, not a congressional mandate. This is the mission space of the Emergency Care Coordination Center. We have 4. We usually talk about them in terms of 3. To lead government's efforts to create a patient and community-centered emergency care system that's integrated, that's high quality. Because if we do those 3 right, we have built the foundation for a larger response. So I live in the office of the Assistant Secretary for Preparedness and Response, Dr. Laurie, and Dr. Laurie's mandate to me when I elected to move to DC and take this job was to help her to make sure that we get it right day to day so that on game day we can scale it up and we're ready to go. I will say that it's interesting to think about this shop living in Asper, because most people associate Asper only with large-scale disasters, do not think of it as part of Health and Human Services per se, probably more associated with FEMA than Health and Human Services. And candidly, internal to Asper, the number of folks that have an emergency response, emergency preparedness background compared to those that understand how healthcare gets delivered in the United States is not a fair 50-50 spread. I have 3 sort of key points and observations and 3 recommendations. And I, unlike it seems many others in this room, am afraid of Marco strong-arming me. So number 1 is that, it is hard for me to believe that we should be thinking about trauma care and not the broader mission space of unscheduled stuff, unscheduled critical illness. I know that is not the mandate of the committee, but I wouldn't be honest with you if I was telling you that I thought that was the right way to go. And the Future of Emergency Care report had emergency and trauma care squeezed in every time. I think many read that. I think many didn't understand why trauma care would be there, but STEMI care and cardiac arrest care and stroke care wouldn't be there. Serious infectious diseases such as H1N1 and Ebola taught us a whole lot about our healthcare system's interest in managing these conditions. So I'm ready to be manhandled by more than just Marco now. Number two, efforts to improve emergency care have focused on, historically, if you go back and look at, and many have referenced this already, sort of block grants and system building stuff, we used to think about engineering a system. We have allowed trauma care now to live in a very narrow space, which is not engineering, it's financial incentives in the healthcare sector. There are public health initiatives, there are perhaps disaster preparedness initiatives, but we've allowed ourselves to think about trauma care. Internal to the federal government. The conversation about how you fix trauma care is largely a conversation about how CMS is going to build incentives to think about trauma care. And then number three is number one, because it's so important. Or because PowerPoint did whatever it wanted to do with my numbers, is that I'm seeing the maps here today from the shop at Penn that Charlie Brannis, in that 2005 paper. Charlie's my mentor, and we got the contract together to build those population access maps for trauma. We built them for stroke. We tried like heck to get AHA and NHLBI to let us build them for cardiac arrest and STEMI. We never did. They're a population-based planning strategy, and there are no population-based outcomes. Right? No one holds my feet to the fire if the shop down the street in the private sector doesn't transfer me their most critically ill patients. And we know we have a penetration problem there. Ellen's paper, it changed the world, for sure. And we also know through a simple analysis you can do online using HCUP data at ARC that half of injured patients in the US don't come to a trauma center, and a third of severely injured patients don't come to a trauma center. And the economic drivers, I don't need to school anybody in this room about, you know what they are. I think there are solutions here, and let me sort of give you three. The first is that we need to be inclusive about all emergency care sensitive conditions. Things for which a rapid intervention changes your outcome deserve to be bundled in one space. The second is that the authority, if we're going to build a leadership and accountability structure, which I think is the mission of this panel. If we're going to build a leadership and accountability structure, it has to be inclusive, number one. Number two, it has to have authorities that bridge all kinds of different spaces. And we're talking about a giant lift here. We're talking about not public health, healthcare, and the emergency preparedness mission space. Because we live in all of those. Brent Eastman said famously in a room down the hall a couple years back, if there's a big event, someone might get hurt. He's right. And certainly we learned from Katrina, they might also lose their meds, forget their insulin in the refrigerator when they leave in a hurry, or not get dialysis because their dialysis center closed. And then number three, obviously, is the big one here, is that I think that this unscheduled care initiative that I'm talking about, that we plan for at the population level, needs to be measured at the population level. I think we need to listen to the advice of the Institute of Medicine report on population-based outcomes and population-based care that said very, very clearly that they thought that the idea that, sorry, I'm going to read it to you, the way that population health is being measured by the healthcare sector is missing the mark. They lobbied for total population health to be used instead. They said, although the healthcare delivery system is increasingly focused on population health, the committee finds that the focus reflects a narrow interpretation of the term population as the patient panel or the group of covered lives. Instead, the committee defines population health as the health of all persons living in a specified geopolitical area. I would say that resonates with all of us as we plan trauma systems and stroke systems and cardiac arrest systems, and that there are nice levers, if we're going to stay within the box, that we are mostly using within the federal government these days to shape outcomes and shape system design. We need to think about financial levers to incentivize population-based outcomes in addition to population-based planning. I look forward to a discussion. Thanks for inviting me here today.
Well, thank you all very much for your presentations. We, again, just for a reminder, we have till 12:15 for comments, questions from the panel. I'm going to ask our committee members that if you do have a question, that it's targeted to one specific person, or at least identify who those folks you would like to address the question from, so we don't have multiple different colleagues who might not be as engaged on your specific question as possible. So I'm going to turn it over to the committee for first thoughts. Dr. Kupas.
When I wrote this question down, I was going to target it to anybody, and actually hopefully several, so we get at least two inputs, but now I'll talk it to anybody but Brendan after some of his last comments. So in the last group, we heard about the developing joint, the joint trauma system, but also how some components of that are still developing a bit. But the perceived benefits of the group as a joint rather than any individual service and what they accomplish and what their cultures bring. Is there a similar leadership model or optimal leadership vision you might have that would lead to a joint civilian sector trauma system, or in Brendan's case, time-sensitive illness system? And how would that potentially be optimized? Would it be a joint group of surgery, EM, EMS, PM&R, nursing, et cetera? Or would it be a joint group with government and private sector membership?
I'll take a shot at that. I mean, we've had discussions about that. I think there are successful solutions that have been created in local EMS systems. At the professional level society, the first thing I think is people need to agree on standards, and maybe now is the time to consider this. If you go back 5-10 years ago, you know, what door-to-balloon time should be was just being defined. What was the appropriate stroke prophylaxis protocols? I mean, those were still being defined. So regionalizing those, I mean, certainly we would be open at the American College of Surgeons to collaborating with other professional societies to create that. But I think it would really have to be driven by, you know, the federal office that now exists and the concepts that really were just floated. I think that's what should be promoted. I think they are mutually complementary. And I don't, you know, I think there have been many people that have advocated for just that kind of system. The biggest challenge, as I see that, in setting that up, is that there has not been the same process of defining a hospital system set of criteria that you would be verified against. So a lot of that has been self-imposed unless I'm not aware of a verification system. So I think developing something similar to trauma center designation would be really important. And when you start talking about taking heart attacks away from hospitals or strokes, that becomes a very complicated local political question.
You know, as a corollary to that, I think sometimes rather than who's in charge, it's what is the problem and what is the necessary solution. And the healthcare or the civilian healthcare sector is changing so fast that it really does require some thought. The payment systems are actually pretty critical. In our system, we're about 60-70% governmental payer and 30-40% private sector payer. So any solution must address both of those. And that's a financial issue. The competence issue, I think the college and other groups have done pretty well with that. The access issue is really important because if you can't get into these systems, you're not going to get care. And there are things coming down now which can significantly influence that. As hospitals go from one hospital to a group of hospitals, who really holds the responsibility if you're 6 or 7 hospital group for the population's care? That is not defined, and there's no accountability for that. So that needs to be part of the equation and part of the solution.
One thing I forgot, if I could just spend one more moment. We had a major transition about 20 years ago. We used to call all of our programs the optimal care of the trauma patient, and we changed that very deliberately to the optimal resources for the care of the trauma patient. And the purpose of that was to be inclusive. I think the same would need to occur for stroke and heart attack, to define what the optimal resources are, because then you can challenge a hospital to step up to that standard rather than having them try and self-impose it. And to my knowledge, those have not been defined quite that way.
And in my response, 7.5 minutes that I took, Doug, I mentioned the word local like 5 times. I just went back and counted it. And I agree that it needs to be joint, but we can't forget local involvement, local input, local providers, anyone who provides service at a local level needs to be involved in the process, because that's the only way it's going to be successful.
So we have John, then Joe.
For the panel, we discussed, maybe before you all were here, rehabilitation, psychological health, and the strides the military has done in those areas, while not perfect, are pretty significant. You know, it strikes me as transitioning from military to civilian that there's great opportunities, that's an understatement, for psychological health and rehabilitation care of all trauma patients, all, not just the ones who have insurance of some kind. Can you address that? And it's almost, I'd like you to think about it like on the front end on trauma centers with EMTALA, where we have to take them. Why isn't there something like that on the back end where we can get the patients who need rehab into rehab centers or into psychological health care?
If I can just take a shot at that. There are some countries in Europe and the Middle East which pay a lot of attention to rehabilitation, primarily because these are young people and you're going to be on somebody's dole for 30, 40, 50 years. So they would just as soon pay a phenomenal amount of money to rehabilitate you back into the society to become a good citizen, useful citizen, and taxpayer. We don't do that. That's not how our system is teed up. And it would require at least thinking on that nature, because then literally as you come into the hospital, you would be starting your return to a productive life. And that is not how our systems work right now, and they should work that. The military system works that way, but I mean, I can't comment for the whole civilian system, but generally speaking, we're interested in taking care of you and getting you better, but not making sure you're functional for the next 30, 40, 50 years.
Dr. Holcomb, is the question a coverage one? Why don't we mandate that those people have access to PM&R resources? Or is it a supply-demand? Why aren't there more PM&R folks that are focused in this area?
It's a system. It's not just one element, right? It is a system, which you're alluding to. On the front end, our trauma system, in general, patients have access to trauma centers by law. On the other end, so if Tom takes care of a guy and rearranges his anatomy and fixes it all up in 7 to 10 days, he's ready to go to rehab so he can become a productive member of society can. But that patient's unfunded, as 25% of our patients are, can't go.
Yeah, for sure. So, I mean,
can't go.
Sorry to dumb it down, but, you know, from an access perspective, access, it means health insurance, you know, to those inside of the federal government. This is the piece that I think they would say, we just spent several years working really hard on this. The first piece was to get everybody into the pool. The second piece is to fix the delivery system. So on the into the pool piece, I think they would say, states that are expanding Medicaid, they should have insurance, they should be able to go. Medicaid is a separate question, I get it. The second piece is, what should the delivery system look like? And I think that, you know, then they would probably say to you, well, so, you know, we do bundled care for CABG. Why don't we create a bundle for trauma? The moment you show up, here's your bundle. Now you got to share money, trauma surgeon, emergency department, intensive care unit, hospital, given this bundle with the long-term care piece. But, you know, they would create a value proposition for a bundle. It's a worthwhile thing to float to CMS if that's of interest, given that context. If the question is, why can't everybody be insured, it's a harder question.
Joe.
For the last 15 years or so, I've been working in patient safety in healthcare. In the field of patient safety, by which I mean sort of harm that is caused during care or as a byproduct of care in a healthcare setting, or response to that harm. In that field, there are measures and there are aims, and there are global measures of safety. You know, so if I was in a hospital system, I would be interested in risk-adjusted mortality associated with harm. I would be interested in all-cause harm, just all the harm that's associated with the delivery of care. There are measures that are there that we can look at to sort of give us a sense of the overall effectiveness of the system. I guess what I'm interested in is, and I should say there are also aims. So we know that, you know, what the best have done. There are some systems that have reduced all-cause harm by 25, 30, 40%, and that gives us a sense of, what we can reasonably expect health systems to do. My question, and I'd like to direct this to Dr. Jacobs, is in this field, both because you made this statement about complete access to optimal care as being the goal. What would be the measures of access and optimal care? Are there sort of prevailing or common or dominant measures? And then what would be the aims around access and optimal care? Do those exist? Is there an accepted standard in the field?
Well, it's a complex question because I think the answer is a population-based answer. And we don't have data systems which do that for us very well. We have mortality, so if you have a lot of people dying from trauma in an area, that's a good one. We should reduce that to a national norm or something of that nature. But in the entry point, we don't really have very good measures. We have excellent measures for that hospital, but not the one beside it. So it generally is a facility or a small group that is really being measured, not the population which it serves. Stated differently, you might have an inner city where one section of the city gets superb care and another section gets terrible care. But we don't really measure that very well. And again, unless you have a regulation which says everybody has the same access to care, it's very difficult to do that. We like that, that's an aim, but that's not a measurable solution.
Could I just add one comment to that? Because I think in a well-organized system that is measured. And so the way you do it is you audit admissions to non-trauma centers. You take head injuries or somebody that went to the operating room for intra-abdominal bleeding, and you require the non-trauma centers in the system to report that, and then based on that audit, you try and correct that. And you can affect triage criteria, you can affect a number of system components, but process error management is probably one of the most prolific parts of trauma data collection, at least until the more recent when we shifted more to outcomes. But trying to get the process of care measured around safety issues was really what defined trauma systems. Are you in the operating room in 2 hours? Was the surgeon at the bedside 80% of the time when you arrived? Those kinds of things were just designed to be safety issues.
I have three questions from the panelists. First, to Dr. Hoyt, this is a question which would require to put your systems hat and your researcher hat on for a moment. Is there one specific quality measure, apart from mortality, that we should be using to measure trauma center outcomes? One specific measure?
Not currently. I think longitudinal outcome, incidence of post-traumatic distress, functional recovery, those kinds of things. We know how important that is. We know how that reflects ultimately the non-mortality outcome, but we don't have good measures and we don't have good data. It's very expensive to collect.
And I brought this up because last time when we were having this discussion, the National Quality Forum doesn't currently have a trauma-specific indicator, so that's why I brought it up. The second question is to Dr. Jacobs. You've done a lot to propose and develop the field of acute care surgery. And of course, now we're not trauma surgeons, we're acute care surgeons. Can you talk about the opportunities that the change of our field to acute care surgery has brought to this, and where is that a good thing or is that a bad thing for trauma care?
I think it's a very good thing because a couple of kind of surgical things. The world has changed from open operations, which are really needed in military and anybody who's severely injured, to pretty much closed operations, which is laparoscopy and things of that nature. So you need to have some way to do both of those skills if you want to take care of trauma in a civilian or military environment. So an excellent surgeon who is not doing open work is not so excellent if you need open work. And that's an interesting issue. The second one is that or environment is you definitely need to have a broad skill set. So from any emergency to trauma to critical care, that's a good set for someone to have. And it's a good career to pursue for 30, 40 years. And then the final is that in the simulation environment, we can do a lot of things which can allow you to do those things and maintain competence in highly lethal things which don't happen very often. And you can simulate that either in any kind of model you want. And I think we're in our infancy there. If you think of what the gaming community is doing now with games, they are unbelievably sophisticated. Now, what the military community does with simulation, we need to move dramatically in that direction. The other thing it does is it standardizes care, and it standardizes competence. So we can assure the public and ourselves that this practitioner has actually seen and done to competence that thing. And these things are pretty episodic and not very frequent, but highly lethal.
Thank you, Dr. Jacobs. And finally, Dr. Carr, you were kind enough to talk about how you equally love strokes and acute MIs as much as trauma. Seeing that we're talking about a learning healthcare system, are there some pieces of advice that you can give us as we envision a great learning trauma system from management of acute MI or stroke that you've seen that we should definitely be implementing in the trauma system?
How many cardiologists in the room? One? Without intentionally offending anybody, what I will say is that it's the opposite. I think this room probably knows that it's the opposite. So when I'm somewhere talking about building cardiac arrest systems or somewhere talking about stroke systems, what I'm watching and sad to be watching are the same mistakes being made that were made by the trauma system, a decade, 2 decades, 3 decades beforehand, building exclusive systems, building a single-tiered system, making a game of winners and losers rather than something inclusive that interdigitates smoothly. It's the errors of the other systems because we're not building a system that troubles me the most. That said, are there lessons that others might rather than the typical flow of knowledge from trauma system builders to other system builders? The question, right, is are there lessons the other direction? Yeah, I guess the only piece that really sticks out, and in fairness, it's not something I've thought about, is the engagement piece for the community, for patients, for people that might someday be patients, has been really, really impressive by the CARDS community. The bystander CPR and the presence of AEDs. And there's been some mention of Hartford and some of the initiatives that are happening now internal to the federal government about bleeding control. And so I think that is something that probably the acute care surgical community, it's not like they're not on there. There's certainly been plenty done by the acute care world and the trauma world and prevention. But that is one piece where I think maybe CARDS has the edge on you. It's not, in fairness though, to your question, it's not a system design piece.
So on deck, Sarah, you're up. Tom, Ellen, Don.
So my question is for Dr. Carr, but any of the other panelists could comment as well. You had mentioned that having authorities that bridge public health, healthcare, and emergency preparedness is an important step forward. And I was wondering, particularly given the fractionated or differing authorities that we have, both legally and from funding perspectives, and even perhaps some differing missions or aims across those various components, how would you think about, or what recommendations would you have for both policy and practical solutions to building those authorities?
Marco, you can't say we're out of time and just make this one go away. It's, obviously it's a weeks-long conversation to get there. I guess, in the macro, I would say that we sat and listened to this first panel and we heard a very clearly mission-driven agenda. And then we celebrated the fact that when you set your sights on something, you can get to it. In the absence of having set our sights on it, I think we shouldn't be surprised that the system of care delivery that we have is less than we would want it to be. So that's, in the macro. In the micro, I think I would say that, there are really good building blocks here. Maybe I'll highlight two. My office convenes something called the Council on Emergency Medical Care. So we have no ability to influence the agenda of other organizations, other agencies, departments, but we do convene them, and we talk about priorities in this space. We talk about strategies. We talk about overlapping mission space. We find synergy, and that room includes folks from transportation. Drew sitting behind you includes folks from DoD, lots of them in the room. Folks from VA, folks from FDA, as you know, folks from it could go on, but certainly within HHS as well, CMS and SAMHSA and HRSA, all the different pieces that touch the emergency care system. So convening is a start, identifying shared priorities is a start. And then the second one that I would be remiss not to highlight is my boss, right? I mean, the Assistant Secretary of Preparedness and Response, that position was created, position was created to create more, or to develop more of a one-stop shop for this intersection that we're talking about, the preparedness space, the public health space, the healthcare space. And so the degree to which, and I'm sure you all watched the hearings as I did on the Hill, the degree to which the Ebola response leadership was in the White House, was at the CDC, was in HHS, is sort of all part and parcel to the conversation or the question that you're asking me. How do we get there? And the answer is change is slow in the federal government. A lot of important building blocks are in place. But the real answer, of course, is a congressional mandate, a congressional development of a mission space to make sure that we fix this.
I wonder if I could just comment. One of the things which I certainly learned, but I think most of us on Harvard Consensus learned, is the charge was to increase the resilience of the citizen. The citizen is everybody. Most of us more focus on what we're doing, hospitals or government or payment, whatever it is. But the citizen is a little different. So you had to have a lot of different people in the room. All of them are highly opinionated, and everybody has to give a little to get a lot. And although that's a pretty simplistic thing, that was the only way that we could move this agenda forward, because military operations are different than civilian. Law enforcement is different than fire and police. It's different than health. And legal is different. And everybody had to give up a little something to come up with a document which may or may not be a good document, but it was a document everybody could agree to. And what I learned is you got to give up, you have to have a mindset to give up something to get something.
Tom?
Brandon, I completely embrace your concept. Actually, as we built the new shock trauma center, we designed it to do exactly what it was you articulated. We should talk some more. The question I have for you guys is about motion within a trauma system. We always talk about, did the patient get into the trauma system, and then the discussion stops. But we see, for instance, people that have polytrauma mechanism, they go to a trauma center, they have an isolated facial fracture, and now that has to come downtown because the level 2 trauma center decides on Saturday night they're not going to address that, or the isolated fracture, or the isolated tiny brain injury. Why is it because it's subspecialty care that doesn't get addressed? Why isn't that audited as part of the way the trauma systems operate? Or am I just missing something here?
Well, this is a tough comment to make because it's about us as physicians. What was the challenge 25 years ago with trauma systems? It was getting surgeons to be willing to do it. EMS community was ready, government was ready, payers were ready, the patients certainly were ready. And I think it's the same argument for door-to-balloon time or stroke. I mean, there are places that have said we're going to do this and they're excellent, and there are places that have to try and leverage the physician community into doing it. That's what's going on at a level 2. I mean, they can say it's about money. I've learned that I don't believe that. I think it's really about there are people that are interested in caring for these patients, and there are people that find it as a great undertaking, and burns perhaps is the even most severe type. I mean, there are a lot of people that just don't want to take care of burn patients. So, you can try and leverage that, or you can build a system around people that want to go positive and really build the system around people that want, and then support the put through, et cetera. So, as I've thought about this over the last period of time, and I've been in the same position you have where you're trying to get somebody to do the right thing, and I don't actually think that's possible. I think we have to reset the value system and create a compensation system that rewards people, but then go for the people that really want to make this work and work with them. That's the infrastructure that will do it. The military, and that is quite frankly the service culture that's so attractive to partnering with them from my standpoint. When Eric Elster and I sat down and talked about what could we do together with the college, it was really about looking at the fundamental professionalism of both surgeons and military physicians that we said that's something we can build on. So I hear you, Tom, but I don't, after trying for 40 years, I don't know how to force somebody to do something that they don't want to do.
It's interesting to me that in a global budget, you are still seeing that so much, right? You guys have a lot of different things that are different in Maryland. Your budgeting is different in addition to your trauma system structure and oversight. But I hear that question in two different pieces. I hear on-call responsibilities and maintaining your on-call schedule and making people respond when you need them. And the second piece, I guess I hear is, or I think about is, if we were all in the same health system and I decided to only have a face guy be on call at the mothership, right? I could cut a lot of costs for the rest of the system, and I'm getting told over and over that it's about value, and the denominator requires that I decrease cost, right? So I can drive value up. It makes good sense financially to not have a face guy be on call at 15 different shops and to have one at yours that's busy all night.
Yeah, it only works until you overrun the mothership with the facial fractures, and now you call me and you say, this guy's really sick, and I'm looking around and going, fed?
Yeah, but this is if there's one thing we're going to pay attention to today, this strikes me as a really crystal clear one. Just-in-time supply chains are great until there's a disruption in the just-in-time supply chain. And I think that's what you just said. The military is not interested in being 100% lean at all times. They like the idea that there are redundancies. So if we're going to learn from them, we probably need to learn that a really, really efficient, if that face guy is operating back-to-back all night long and the beds are steady at 100%, everything looks great. But the hiccup is what we're all worried about.
So real quick, I couldn't help but look at a pre-hospital perspective. I mean, we have a lot of data about getting people to, whatever level, and whether that's ever been analyzed or not, I'm not sure, but we have a lot of data we've collected from the pre-hospital setting to do that. And now at the pre-hospital level, we're looking more into STEMI and stroke and moving that forward because we can see the benefit, and we're looking at what we can do, copy what the military does because they do it on the battlefield, and they take care of patients there and then move them there quickly. And so we're thinking, what can we do to get our paramedics to be able to do that, to be able to help alleviate some of the complications of potentially having to board them or do whatever when they get to your facility.
Yeah, but what can we do is a different question for NASEMSO, I think, right? Which is guidance and leadership and sort of best practices and things of that nature. If we want what can we do to turn into the current model, which is create financial drivers, the question I think to the EMS community would be, is that something we want? Do we want systems that are high performers and can, in one of the first slides talked about the transition of days to hours as we move people through the system once they're injured on the battlefield. It's a powerful slide. Those quality metrics applied to the National Quality Forum and built into the civilian sector would be really interesting to Adil's question, right? A really interesting answer to Adil's question. I'd like to know, across the entire continuum of care, where were there gaps and why were there gaps? And how do we share accountability for those gaps? And it's a real question about whether or not EMS is ready for that. Hospitals and physicians were not, I think we could say pretty clearly when the hammer came down.
So Ellen, Don, and then Ellen.
Since this is really about the learning health systems and the leadership around driving the institutional capability and capacity for executing trauma in the country, There's a couple of themes from the panel members. One is public health model. Two is lack of data and transparency about that population and how it translates into how we give access and reimburse for it. So my question to the panel, specifically Dr. Jacobs and Dr. Carr, how, from a leadership perspective, who is defining the learning system? Not necessarily for the clinical capacity, because we have a pretty good example of cooperation and partnership across, but defining the where access is a problem and actually saying, well, is this a national mandate that we give access to care for equally across, based on population data? Or is this really about incentivizing private and public and hoping for the best? Because I think that's a fundamental leadership question. It's a policy question that I hear from one half of the panel that should be very local and state-driven, whether it's county or state, but within the states. And then I hear on the other side that this is really a national challenge. So I'm looking for some guidance from you as to what's the right answer. I mean, how do we address this?
Let me take a small crack at it. If you think of, say, a fire philosophy, you have a tremendous amount of availability right now, from the smoke detector, the fire detector, to the fireman in the house. The public does not argue about that, primarily because Chicago burned down and some other things like that. So they know that this is something critically important. However, the number of fires in modern cities is vanishingly rare because of all of these things. But the philosophy has not changed. You will still have firemen in the house 24/7 doing not very much because there's no fires. So we don't have that if you're in a motor car crash or a gunshot wound or break your hip at home. That is not the philosophy of the country. So that is a fundamental change that needs to occur. It might occur with increasing the resilience, if you will, of the citizens, because it's really not your problem. It's somebody else's problem. But if a bomb went off right here, right now, it's your problem. It's my problem. And as soon as you go to that place, your entire philosophy changes. And I think that is what, at least that's the message I got from national security and people like that. That's what they want. And the why is because there's a potential for those kind of problems to happen. And it's more than a potential, it actually is happening. So there's a window here to change the philosophy. Once you have the philosophy change, I think you need an organizational governmental structure to do that. And it could be local, it could be federal, it could be actually all of the above. And once you have that, then you need to have some kind of payment system to assure it, public or private. But once it comes down that way, you will have a system which you cannot take away. You try and take away fire services from your community and see how fast you get unelected. It cannot happen. Even although the evidence of fires and whole cities burning down just isn't there. So it is a philosophic thing which we need to encourage our leaders to embrace, because as soon as they do that, then this organizational systems will come into play.
I actually had a couple questions. You said that you've heard us say that there's a call for a public health model, and I don't know. I guess I don't know what that means. I'd like to make sure we're using the similar language around that.
Population health driven, basically.
Gotcha. Okay. Not infectious diseases and grant money driven, right? Which is often what people, when they say public health model, they mean. Okay, so yes, population based.
Which, from a learning health perspective, would include all of the education and training and the research and the structure and standards that go along with how you address a community and the population, the needs, the health needs of that population. Your model that you described, but I can't reconcile between the gaps that you've defined and doing local and how that works from a leadership perspective. Do we have to have a national set of standards that says everybody will based on some kind of demographics, or are we going to say no? It is going to be incentive-based. It's based on payment models.
Well, you know, I mean, I don't think that Paul and I are on different pages around this. I think that the mission space, we could both identify. It would be better if really sick people went to places that can take care of really sick people. Okay, we might agree on the mission space. Now, whether or not we're going to mandate exactly the course that you take or exactly the way that you audit your EMS units to make sure that they're over and under triage or somewhere within the ballpark, that I think those whether that happens locally or centrally, I think is something that could be agreed upon. I'm not sure.
Somebody said something about
weigh in on this too.
An individual. Someone said something on the panel that there was one organization that failed to transfer a person who really needed the care in the other hospital because they were competing for the same capability in the same space. Does that happen a lot?
It happens. What you're identifying is absolutely a need. So I lived in California for 35 years, and you could drive from the Mexican border to Oregon and drive in and out of places that had the best and some of the non-existent care. So when you have that problem, you've got to have a higher authority that will say you have a responsibility to offer this to your citizens. That is the piece that's lacking in the United States. We had it intended in 2002 federal legislation. That office went away. But that was the design, or that was the concept, was to have an oversight, not to be the FAA necessarily, but to have a concept to complete the system. And it's still needed.
I'd like to ask a quick question to Dr. Hoyt and question to Dr. Carr. David, a small point, but I'd like to expand on it. In your presentation, you said something about the large hospitals autonomously making decisions about expanding their trauma care, and you used the alternative would be a needs-based approach. I heard you correctly? Could you just say a few more words about it for us, and then what should we do about it? Should we do something about it, and if so, what should we do about it?
It's a great question. I mean, it was realized originally in trauma systems planning. Some states tried to put a metric in, so a population, the number of centers relative to to provide a volume performance opportunity so that you didn't over-designate and dilute the experience available to a community. What happened is that in trying to pay for the system, trauma centers slowly developed the practice of essentially charging what they charged, and non-players had to pay that burden. As we got into more organized systems of care, for instance, in California, Kaiser was really underfunding the trauma system in California. And what they started to do is push back. And what we're now seeing with the larger systems is they're starting to say, based on finances primarily, that they want to designate their own systems. And this has happened a lot recently in Florida. Florida had one of the most organized systems in the country, and now it's starting to over-designate. So what is needed is some basis to rationalize how many centers you would place in a population. You have to balance that with access. So if you have an area that is not underserved, do you designate a smaller hospital and build them up? Do you put transportation facilities closer to them so that they can access the bigger system? But that kind of system planning needs metrics and needs a consensus-based conference. That's what this group in August is going to try and start to do again. But it's right now the big hospital systems are just sort of voting with their feet, and unfortunately some of the state legislation that is designed to prevent this is actually not being effective. So I hope
Dave,
that answers.
Would you counsel that this authority to designate or to
I think
allocate?
calling for metrics that would rationalize this. You can throw in transplant centers at the same time. But yes.
But would it be state level? Would it be voluntary? Would it be federal?
Well, I think we need a different solution than we have done, because I think, you know, something like the federal banking system or some different way of organizing that need, and then the entitlement that might come along with it to sort of provide for that need. But we have problems in between state borders. We have county to county problems, and then we have the big hospital system saying they're going to take over. So having, I think, some statements along that line as to what's needed would be very useful.
And Brendan, can I ask you a question? I don't want you to mince your words. I'm inviting you to be bold. You edged into the position that we're doing the wrong job, that we're trying to optimize a trauma system, and should we optimize? It might be better to optimize a system for unpredicted, time-critical care. So how bad a mistake are we making? That is, if we stick with our current boundary, would we be doing damage, do you think, systemically, or is this just something that would be nice to do if we could expand to time-critical care?
I guess I would ask who might fund the next committee? Who is the equivalent of the DoD's power to spearhead something like this for other terrible things I hope don't happen to my family? And you know, I don't know that that lobby exists out there, right? I don't know that there is someone who's developing that. So do I think you're doing harm? No. I think building the trauma system decades ago is an amazing thing. We've learned tons from it, and over time it has the creep into the other space has taught us tons. I just think that there are lots of folks whose lives will be touched by missing out on optimal care if we don't paint with a broader paintbrush. Yeah.
Ellen.
So the other Ellen really asked my question, but I'll just use this opportunity to just go a little bit further. So, and it came up this morning in our conversations about the need for national federal leadership, a lead agency at the federal level. And this has been recommended over and over and over again, and it hasn't happened. And I guess I'd ask, and maybe I'll ask Dave his thoughts on why hasn't it happened, but more importantly, what can be done to change that. I'm not sure I totally agree with you, Len, about the will not being there. You know, you go back and look at the survey Howard Champion did of consumers out across the country, and they, as I recall the results of that survey, everybody thought they had access, and they thought that access to trauma care was as important as fire, police, etc. So I think the will is there, but why is this so difficult?
I don't have a great answer for you. This is something I've spent most of my professional life thinking about as well. I think historically trauma was looked at as somebody else's problem, so we are still overcoming that. I think today most people think we do have a system, and we have a great system. It's just not a complete system, so I think it's under-prioritized. I think a consortium that would really include the American Hospital Association, all the other hospital associations, the providers, the government. DoD is a great partner here, I think, because they've always been sort of on their separate own agenda, except for some combined research things. Now that we're coming together in this system, this is a huge opportunity to get everybody's attention. And I think, I'm really looking forward to the output of this meeting and your results. I'm looking forward to our collaboration with the DoD to see what elements we can define. And then I think we're actually looking for and hope to turn this into a major campaign to go up on the Hill and begin the discussion again, just to try and get the system completed. Because I think it would be tragic if we stopped where we are now.
So we have 10 minutes left. It'll be me, then Leon, Joe, John. So 3 questions. First is a very simple one. Dr. Carr, it's obvious the Emergency Care Coordination Center, in essence, we're looking for leadership. This conversation is all around leadership. Have we found the home for leadership within your office? First question. Second question, tell me now, the congressional appropriation for the Emergency Care Coordination Center or the budget that HHS has designated for the Emergency Care Coordination Center. And then I have one follow-on.
I'm sure that'll be wonderful as well. The spirit is willing. The congressional line item is 0. The internal budget from the secretary is 0. The reappropriated funds from other entities is about $800,000 all to staff.
Thank you. Good to know. So very interesting to see your pivot from what our discussions around trauma care to acute, unscheduled, time-sensitive conditions. And we see the implications of developing a formalized trauma system and how that has, and you know, Dr. Holcomb's educated me on how the ripple effects if we get trauma right, cardiology kind of blends on, stroke kind of blends on, sepsis care, pediatrics, whatever these specialty agencies are, start to develop similar types of constructs to where trauma care is. However, they remain distinct and they remain separate, and maybe they're not as unified as we could potentially be. We saw the military think about pre-hospital care, and I'm going to just put a foot stomp on pre-hospital care for 1 second, and thinking about the continuum of care. And what they found is there was really an omission from their perspective on data analysis from the pre-hospital perspective. So, and this is a question specifically to Dr. Carr and Mr. Patrick. In your rejiggering to allow us to think about acute unscheduled care, which would include trauma care as one of the tenets to acute unscheduled timely care, tell me how what the military did and the lessons learned to include pre-hospital care is, and the data analysis for that, is linked currently within health delivery reform efforts to improve the continuum of care from point of injury all the way through to rehabilitation. Show me what that looks like from your perspectives. And then also the follow-on to that is, how is value being linked to what a system you might define as regionalized, how is value defined for regionalized acute unscheduled care?
I mean, that was a big question. Let's start with EMS. Payment for EMS is based upon transportation, not healthcare delivery. So if I call you, I'm having an asthma exacerbation, I can't find my inhaler, you give me a neb, I feel better and want to then go to CVS and pick up my refill that's waiting for me for my albuterol. I'm not allowed to, otherwise the ambulance doesn't get paid. If I ask you to take me to an urgent care center, a lower cost setting for the same condition, because I don't have an albuterol refill waiting for me at CVS, the ambulance bill doesn't get paid. I need to sign out against medical advice. So I guess I would argue that pre-hospital care is one of the only things that in the current delivery system reform initiative is working counter to the initiative to sort of increase value by decreasing cost, or primarily by decreasing cost. And the reasons for that we can talk about, but they are largely based on the payment strategy or the payment statute for out-of-hospital care. Is that a good start? You take the hard questions.
Yeah, right. No, that was a good start. But that is changing as well as we look at different ways to change that. A lot of times that directs back to the state level. States can designate where an ambulance can transport to and designate reimbursement that is being accepted. And we're also doing some other projects now in cooperation with NHTSA to help develop some guidelines that will move us towards potentially changing that payment model. So, we're very aware of that. Also, the pre-hospital providers are a very willing workforce and are willing to do new things, advance their techniques, try new things, and not really worry about whether they're going to get paid for it or not. As in particular, they just want to do it because they see it in the best interest of the patient. So your question about how did the military do that, a lot of us through educate, they had a captive audience. They brought in their personnel. They trained them to do this. They saw it was successful and moved forward. And I think the same thing would be very true in a pre-hospital setting. We would be able to change the education component, bring it forward, bring it there and do it. And the reimbursement wouldn't be as much of an obstacle at that level as it would by the time they arrive at the hospital. And at pre-hospital level, we don't do much at all at rehabilitation except transport the patient if they, do the call to do that. So that would have to be a different question.
Yeah, I think maybe just to piggyback, it's important to really think about the out-of-hospital workforce in the U.S., and I apologize for not knowing the numbers. I certainly, have them in other talks, but they're not front of mind right now. This is a giant volunteer piece in the United States. This is the service ethic ethos that we referenced in the military before. So these are willing partners. This is not about not willing partners, and we would be making a giant mistake if we didn't say today that educating ourselves about mobile integrated healthcare, community paramedicine, all the initiatives that are happening to use these people that are comfortable being the one place that most of us in the hospital-based system are not comfortable, which is someone's house, someone's neighborhood, talking with them about those real issues of their day-to-day life. It's enormous, and there are CMMI Innovation Center projects around this that could change payment. There are amazing local projects around this that I'm sure Paul could talk to you about forever and a day. But your other question was, how do we know if we're getting what we pay for? I think. What do we know about the value of out-of-hospital care? What do we know about the value of I guess rehab services is in there too. And I think that given what I said before, the way that care is paid for does not allow us to have great insight into the entirety of the scope of or the spectrum of healthcare delivered. We see the hospital pretty well. We have some blind spots.
And I would be remiss not to talk about our current Compass project that we're working on now, which is dealing with meaningful measures. I mean, we're into that process. We're about, what are we, Drew? Another about a year away from that, which is being funded by NHTSA, which is a great project in helping us develop meaningful measures, which we all have agreed will lead towards reimbursement and lead towards all the things that Dr. Carr and that you were mentioning as well, as we're going to change that at the pre-hospital level. So we're down the road a lot further than probably anybody else as far as pre-hospital care and getting to the answers to the questions you asked.
Yeah, but I feel like I need to say that's Drew's leadership, that's Paul's leadership. That is not a coherent voice coming out of the Department of Health and Human Services, right? And this speaks to the mission space problem that you guys have been talking about. Drew is an amazing asset to the federal government. This is vision of the Office of EMS. But how that crosstalk happens, and it happens, but does it happen in as robust a way as it might between the Department of Transportation and CMS? Harder.
Thank you. Leon, Joe, John.
This is a question for Dr. Jacobs. You alluded to this earlier, and that's workforce, when you talked about incentives. I'm wondering, as we look at this potential partnership between the military and civilian trauma systems, any long-term implications for trauma workforce? Have you thought about that much at all?
Sorry, it is a very important question because a lot of it is actually driven from the huge debt that is incurred by students. So they get to the end of medical school and they really do have to start paying back that debt. So they drive towards an environment which can satisfy that. Classically, the trauma environment in a city is not necessarily that kind of environment, primarily because of the stratification of penetrating inner city urban trauma, which is not particularly well compensated, and blunt trauma. So, but it's the penetrating trauma and the severe blunt trauma that military people need to see to be really, really good when they get into a penetrating environment in Afghanistan. So it's a very logical and symbiotic group of people. People over here who are not really seeing a whole lot of trauma, who will see trauma in the battlefield, and people over here, or hospitals over here, that are seeing a lot of trauma that need a lot of help. So it is an excellent training opportunity and an excellent long-term opportunity, because the other change that occurred is, as you're going to 24/7 in-house capability, you need a lot of people. You need 4.2 people to service one of those. And that, again, is a big workforce issue. So the more you can get these partnerships going with people in a military environment who want to have that opportunity, education, vocation, and the civilian environment who wants to do that, but the compensation is not there to do it. That is a very good synergy, which will actually help people who are injured.
1 minute for each question and answer following up. Joe.
So I guess I'll direct this to Dr. Hoyt, but anyone could answer it sort of rapid fire. Are there examples of, so we know there's a lot to learn from the military system and vice versa, but are there models of trauma care or response to unscheduled harm and learning systems around trauma in other countries or in other settings that the committee should know about and study that are considered best in class or within this country?
Well, one that comes to mind, Dr. Holcomb raised before in terms of rehabilitation. I think probably the most organized system approach to that is in Germany or Austria, where really the government has funded it, so it works. But you know, the goal of rehabilitation as part of the trauma system in those two countries is really to restore you back to functional utility. So they have programs that are very innovative along that line.
And I think if that's the back end, the front end in the citizen resilience would be probably Israel. So their citizens are really empowered to get involved and get going. And their response systems are designed for that as well. So you have that as an exemplar on the front end, and probably Germany and Austria, I'm thinking, are the ones I think are probably best. Switzerland on the back end. Actually, both have something to do with the government. One is for different kind of reasons, but they're both driven by governmental policies and governmental funding systems.
So the DoD, through the leadership of Warren Dorlack and others at Launchstool, established a process where there was transparency in outcomes and weekly learning by audio and video teleconference that occurred discussing outcomes of individual patients. That's a transparent learning system. It's probably one of the best examples in the whole DoD. I find very little of that happening in the civilian system. This transparency, identifying outcomes of groups of patients by center or system. In the civilian sector. Can the panel address the value of transparency and outcomes driving improvements in systems in the civilian world?
Yeah, I think, you know, quality improvement in this country is really sort of going through a tremendous transformation. And I think in addition to committing to data systems to collect data, creating learning collaboratives is the essential component, in addition to culture and a few other things. But what you're describing to me is a collaborative, and you know, they do exist in trauma. They have been hard to establish because of competition. You have to have leadership. We had a successful one that's still running for 30 years in San Diego, that all the trauma hospitals got together on a monthly basis, reviewed every complication and every death. And my peers were my colleagues in other hospitals, more so than in my university hospital. But that is culturally a difficult thing to do. So I think the more this becomes just sort of part of the fabric of medicine, John, I think you're going to see it pick up. But I think that the collaborative that the military did and showed how you can use telecommunications techniques effectively, I think, you know, that's all very, very, very useful.
Well, I want to thank the panel. Apologies to Rita that we didn't get to her question. Do you have one? A comment? Final comment for the day, or the panel?
Just because it was very timely, because the, ProPublica just published this big surgeon scorecard, which was essentially reporting in, it seems to have caused quite a flurry because a lot of doctors don't feel it's accurate, don't like it. I mean, and my other just comment is, it's not, although I certainly agree with you on transparency, the states, New York and California, that have done public reporting for years, it's not clear that certainly patients use that data. But I think it's a good point.
I want to thank the panel very much from the committee. I want to apologize to the committee that we've been shortened again for our lunch, and you can throw things at me later. Thanks very much.
Thank you. Let me thank David. for your leadership. We are constrained, so your lunch, which was supposed to be 45 minutes, is now 25 minutes. It's okay to bring food back up to this room.
That's right.
Into
For
this
the
room.
committee, the lunch is going to be in room 114, so you can go pick it up and bring it back.
Committee go to
here.
114,
For
be
the
back. We're going to
audience,
start at
the
1.
cafeteria is down in the basement.
1:30. There'll be three. We have 3 panels this afternoon, and Adil will be facilitating the one on information systems and use. Brent, I hope you'll speak up a lot for that one, and other things. Doug is going to facilitate the panel on clinical guidelines, and then Bill on education and training. So please be back here at 1:30. Thanks.
I know.